Check, halo, this. Attention, ladies and gentlemen. The opening ceremony of International Webinar Series 2021 on Nursing at University of Muhammadiyah, Kudus is going to be started. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Welcome to the International Webinar Series on Nursing at University of Muhammadiyah, Kudus. The Excellency, Rector, University of Muhammadiyah, Kudus, Mr. Rusnoto, Master of Epidemiology. The Excellency, Professor Dr. Aisyah Indah Palupi, as the Education and Culture Attaché on Embassy of the Republic of Indonesia in Manila. The Honorable All Speaker, Errol Francis Sumile, PSD, Centro Escolar, University, Manila. Professor Tiffany Wang, National Taipei University of Nursing and Health Science, Taiwan. Profesor Bisma Murti, Universitas 11 Maret, Indonesia. Mrs. Indana, Master of Nursing, Pediatric Nurse Specialist, the Dean of Health Science Faculty, University of Muhammadiyah, Kudus, Indonesia. The Honorable Vice Rector for Academic Affairs, Mrs. Nur Hidayah, Master of Health. The Honorable Vice Rector for Administration and Finance, Mr. Rizka Himawan, Master of Psychology. The Honorable Vice Rector for Student Affairs and Cooperation, Mrs. Anni Rosiana Masito, Master of Nursing, Mental Health Nurse Specialist. Superintendent of Taipei Hospital and Taiwan International Healthcare Training Center, and all participants. In the name of Lord, today we are gathering virtually in our international webinar series on nursing at the University of Muhammadiyah, Kudus. Singing National Anthem of Indonesia Raya. Ladies and gentlemen, please all rise. Please sit. Reciting the Holy Quran to Miss Naili Nazuli. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. A'udzu billahi minasy syaithanir rajim. Bismillahirrahmanirrahim. Aqimis sholata liduluki syamsi ila ghasaqil laili wa qur'anal fajr. Inna qur'anal fajri kana mashhuda. Wa minal laili fatahajjad bihi nafilatan lak asa an yab'athaka rabbuka maqaman mahmuda. Wa qur rabbi adkhilni mudkhala sidqin wa akhrijni mukhraja sidqin waj'alni min ladunka sultanan nasira. Wa qul ja'al haqqu wa zahaqal batil. Innal batila kana zahuqa. Wa nunazzilu minal qur'ani ma huwa shifaa'un wa rahmatul lil mu'minin. ولا يزيد الظالمين إلا خسارا. وإذا أنعمنا على الإنسان أعرض ونأى بجانبه وإذا مسه الشر كان يئوسا. قل كل يعمل على شاكلته فربكم أعلم بمن هو أهدى سبيلا. صدق الله العظيم. Wassalamualaikum warahmatullahi wabarakatuh.
Speech from the Chair of International Webinar to Mrs. Ani Rosiana Masito, Master of Nursing, Mental Health Nurse Specialist. The floor is yours.
Assalamualaikum warahmatullahi wabarakatuh. The Excellency Rector University of Muhammadiyah Kudus, Mr. Rusnoto, Master of Epidemiology. The Excellency Professor Dr. Aisyah Endah Palupi, as the Education and Culture attached on Embassy of the Republic of Indonesia in Manila. The Honorable all speakers, our Francis R. Sumail, Centro Escolar University Manila, Prof. Tiffany Wong, National Taipei University of Nursing and Health Science Taiwan, Prof. Bisma Murti, University 11 Maret Indonesia, Mrs. Indana, Master of Nursing Pediatric Nurse Specialist, Dean Health Science Faculty, University of Muhammadiyah Kudus, Indonesia. The Honorable Vice Rector of for Academic Affairs, Mrs. Nur Hidayah, Master of Health. The Honorable Vice Rector for Administration and Finance, Mr. Rizka Himawan, Master of Psychology. Superintendent of Taipei Hospital and Taiwan International Healthcare Training Center, and all participants. The first, praise be always to the Lord, Allah Subhanahu wa Ta'ala, who has given us so many gifts and health till we are able to participate in this international webinar today. It is a routine event held every year with other universities that have collaborated by MOU. These activities is followed up to the MOU agreed. This year, University of Muhammadiyah Kudus held an international webinar which is divided into several sessions, namely 1. Nursing International Webinar, Part 1 today. 2. Pharmacy International Webinars. 3. International Midwifery Webinars. 4. Nursing International Webinar, Part 2. Hereby, 4 countries are participate in each webinar sessions. Those are Philippines, Malaysia, Taiwan, and Indonesia, with more than 800 participants. This activity held from June to August 2021. This activity is the first step so that we hope that other activities can be carried out together like joint research, student exchange, lecture exchange, and other academic activities. Thank you. Hopefully this webinar will be useful for all. Wassalamualaikum warahmatullahi wabarakatuh.
Welcoming remark from Rector University of Muhammadiyah Kudus, Mr. Rusnato, Master of Etymology. The floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Allahumma shalli wa sallim ala sayyidina Muhammadin wa ala alihi washabbihi ajmain, amma ba'du. Good morning, ladies and gentlemen. The Excellency Professor Dr. Aisyah Indah Balubi MBD, the Education and Culture Attaché and Embassy of Republik Indonesia in Manila. Terima kasih sekali, Prof, dari Duta Besar di Manila.
Terima kasih kembali Bapak Rektor. Ya.
The Honorable all speakers, Earl Francis R. Sumel, PhD, Centro Escolar University Manila. Prof. Tiffany Wong, National Taipei University of Nursing and Health Science, Taiwan. Prof. Bisma Murti, PhD, from Universitas 11 Maret, Indonesia. Ms. Indana, Master of Nursing, Pediatric Nursing Nurse Specialist, Dean Health Science Faculty University of Muhammadiyah Kudus, Indonesia. The Honorable Vice Rector for Academic Affairs, Mr. Nur Hidayah, Master of Health, Mr. Rizka Himawan, Master of Psychology, and Mr. Ani Rosiana, Master of Nursing, Mental Health Nurse Specialist. Superintendent of Taipei Hospital and Taiwan International Healthcare Training Center, and dear participant of first webinar conference series today. Ladies and gentlemen, firstly let us praise be to Allah Subhanahu wa Ta'ala, the Lord of the world, and the sequel is for those who keep their duty into Him. Father, there will be no hostility except against wrongdoers. Secondly, salawat and salam in Saint Honorable Prophet Muhammad Rasulullah Sallallahu Alaihi Wasallam, his family, all his disciples, and those who follow them in goodness till the day and judgment. In this very special occasion, I am pleased to welcome you to in the international webinar series and public health entitled Stunting and Tuberculosis, held by University of Muhammadiyah Kudus in collaboration with Centro Escolar University Manila, National Taipei University of Health Science, Taiwan, and TIHTG, Taiwan. This webinar aimed on how to eliminate both stunting and tuberculosis, requiring a collaboration of multidisciplinary healthcare professionals, multi-stakeholders, and multi-partnership response driven by the human right of its individual and the effect in global pandemic coronavirus disease 19. Ladies and gentlemen, in almost all countries, the stunting rate is more than double among the poorest children that is research, indicating disparity in stunting distribution. Children from the poorest 20% of the population have stunting rates which match the rate of the races quintily. In South Asia, the absolute disparities in stunting distribution between the rich and poorest children are greater than in any other region. Another issue that Indonesia, as an of high burden country for TB, has been determined to eliminate TB at 2030. Many challenges shall be addressed, including TB and reporting cases, increasing drug resistance, childhood and adolescent TB cases, make us have to work hand in hand to overcome them. For many people, the preventive practice introduced to help stopping the spread of COVID-19 are all too familiar. Mask wearing, isolation, distancing from peers and loved ones. And these are things survivors of TB know all too well. The lesson we have learned from our year fighting TB have prepared us for facing the new pandemic. We have the power to better understand COVID-19 and protect people by bringing to light the cutting edge science and research at the world lights from the forces dedicated to end the coronavirus virulence disease. Ladies and gentlemen, I would say that we also be careful and confident with some of the achievement of the Muhammadiyah University of Kudus. Among other things, the change in the form of stickers Muhammadiyah Kudus to Muhammadiyah Kudus University. The was hand over by the President of the Republic of Indonesia, Engineer Haji Joko Widodo. Universitas Muhammadiyah Kudus, the nickname UMKU, is now having 20 study program divided in 3 faculties. Furthermore, to support the internationalization of institution, UMKU has established foreign cooperation with 37 universities, posted on private university in Taiwan, Malaysia, Brunei Darussalam, Korea, Japan, the Philippines, and several countries in Europe. UMKU also has a commitment to empower graduates by working with many hospitals in the Pati Resident, Bandung, Jakarta, and Batam. One of the UMKU's vision is being global. This internationalization conference is one among many efforts to make this vision come true. I believe that by participating in the international webinar, we are in the right place and the right team. Together, let us accelerate the exchange of ideas and scaling up of good practices in pharmacy fields, and I wish you all a very successful webinar. I declare that this conference in official open. Thank you very much all attention and collaboration. Ladies and gentlemen, I want to prepare tuberculosis and stunting condition in Indonesia. Tuberculosis and stunting case Indonesia country profiles. Yeah. profiles country situation tuberculosis Indonesia in 2020. There are estimate case TB 855,000. You can look deaths of tuberculosis in Indonesia. There are very high incident and prevalence of tuberculosis in 20 and 20 years. Next. Yeah. Annual TB incident in Indonesia reached 1 million case more, and the incident rate of TB is 391 per 100,000 population. Indonesia the number of 9 in the world. Next. The case detection rates in the 20 and 20 years, dashboard tuberculosis in Indonesia, I put that's 2000 and 2019 global TB reports. We can see jumlah kasus TB yang ditemukan dan diobati tahun 2000 sampai 2020. There are 4 more case tuberculosis. Next. Estimated of DRTB burden in the WHO, the WHO 20 and 19. Incident MDR post-RTB 62,000. Estimate MDR MRR TB case among notified pulmonary TB case 11,000. Estimate percent of TB case with MDR and RRTB 2.8% and 18 prevalence rate tuberculosis. Laboratory confirmed case there are 2,000 more. Patients started on treatment 1,000 more. Success rate 51%. Situation and burden, TB HIV incident 45,000. Knowing HIV status 14%. TB HIV and RRT 28%, and success rates 60%. Next. National strategic plan in the 2018 until 2020 milestone towards the TB elimination in Indonesia, vision in Indonesia free of tuberculosis, and mission TB elimination in Indonesia by 2030. Number 1, strengthening leadership in the district level management. Number 2, improving access to the quality TB service. Number 3, control of risk factors. Number 4, enhancing TB partnership through the coordination forum. Number 5, injecting community in TB control. And the number 6, healthy system strengthening. The major target for milestone toward TB elimination in Indonesia. In Indonesia, NTB strategy case strategy by 2030. Number 1, increase case notification from 32% in 2018 to 70% in 2020. Expand access to and utilization of expert MTB, REF, as primary diagnosis tool for at least 25% of presumptive TB patients by 2020. Number 3, ensure 80% of GRTB patients are diagnosed and notified by 2020. Ensure 95% of diagnosed GRTB patients are enrolled on treatment by 2020. Improve overall treatment success for GSTP to 90% from 2017 onward, and from GSTP to 75% by 2020. Increased proportion of TB patients with no HIV status from 15% to 50%, 80%, and 75% in 2018, 2019, and 2020, respectively, and ensure all co-infected patients are start an ART. Provide IPT to as less 50% of child under 5 years contact of TB patient. Situation stunting in Indonesia, from nutritional problem in Indonesia di setiap negara di dunia mengalami permasalahan gizi. The number one is stunting. There are 22.2% balita di dunia. Number two was sting, 7.5%, and overweight 5.6%. State gizi in Indonesia di 2013 until 2018, stunting, wasting, overweight, this is a problem serious in Indonesia. Next. Yeah. National problem in Indonesia. This is a present from Indonesia by Indonesia language. Di gambar 4 kita bisa melihat bahwa masalah gizi di Indonesia di tahun 2015 sampai dengan 2017 kita melihat ada 4 kategorikal. Yang pertama adalah gizi kurang, kemudian pendek, kemudian kurus, kemudian gemuk. Kita melihat proporsi gemuk itu paling kecil. Kita lihat prevalensi, rata-rata prevalensi balita pendek di regional Asia Tenggara from 2005 and 2017 diambil dari Child Stunting Data and Visualization Dashboard WHO to 2018. Indonesia, the number of 9, yes. Next. In Indonesia, there are 8 million decrease growth not maximal. 1 dari 3 dari anak Indonesia mengalami stunting. Ini satu ilustrasi bagaimana ciri-ciri stunting. Yang pertama adalah pertumbuhannya yang melambat. Kemudian usia 8-10 tahun anak akan menjadi lebih pendiam, tidak banyak melakukan kontak-kontak mata. Kemudian wajahnya akan tampak lebih muda dari usianya. Tanda pubertas, tanda-tanda yang dialami pubertasnya terlambat. Performa buruk ini akan menjadi perhatian dan menjadi hambatan mereka di dalam melakukan kehidupan maupun proses belajar. Next. Ini dipublikasikan pada 22 November 2018 oleh Menteri Kesehatan bahwa pemerintah telah gencar-gencar yang melakukan upaya penurunan angka stunting dan eliminasi tuberkulosis. Yang kedua, program ini telah dijadwalkan kementerian sebagai program prioritas dalam pembangunan kesehatan di Indonesia. Terobosan yang dilakukan adalah melakukan collaboration stakeholders dan berbagai departemen. Satu hasil riset kesehatan dasar tahun 2018 telah menandakan satu upaya perbaikan dari prevalensi balita stunting yang turun dari 30,8% dari 37,2% di tahun 2013. Prevalensi stunting sudah mencapai target yang diharapkan pada RPJMN tahun 2019 yaitu 32%. Walaupun belum mencapai target yang ditetapkan oleh WHO yaitu 20%, penurunan stunting di Indonesia termasuk penanggulangan yang cukup baik. Dibuktikannya dengan prevalensi gizi buruk turun menjadi 3,5% dari 5,3% di 2016. Ini adalah satu penelitian yang dilakukan oleh Fakultas Kesehatan Masyarakat Universitas Indonesia yang melakukan penelitian relationship nutrition, stunting, and tuberculosis among child under 5 years. Di sini dihasilkan bahwa dari usia balita kurang dari 24 bulan dibandingkan lebih dari 20 bulan mempunyai resiko 2,8 kali terjadinya TB, dengan odds ratio 2,84 kali dibandingkan yang memiliki gizi yang lebih bagus. Balita stunting yang tidak diimunisasi dan mempunyai kontak TB serumah menjadi risiko lebih besar daripada TB. Baik, ini kira-kira di open remark di pagi hari ini. Sekali lagi kami ucapkan terima kasih, thank you for all, serta khusus pada Duta Besar Manila yang hari ini berkenan untuk memberikan keynote speech di webinar internasional. Kami ucapkan banyak terima kasih. Dan pada semua peserta yang tadi disampaikan oleh panitia mencapai lebih dari 500 yang dilaksanakan secara Zoom. Semoga tetap bisa mengikuti dengan baik sampai dengan selesai. Pada para narasumber kami ucapkan terima kasih yang sebesar-besarnya atas kesediaannya untuk webinar series internasional di Das Muhammadiyah Kudus. Demikian yang kami aturkan, kurang lebihnya mohon maaf. Assalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, now please enjoy the video profile of University of Muhammadiyah Kudus.
Islami, berwawasan global, dan berjiwa entrepreneur.
Assalamualaikum. Selamat datang di kampus Universitas Muhammadiyah Kudus. Perkenalkan, namaku Rizky dari S1 Hukum.
Aku Andin dari S1 Farmasi. Nah, kalian pasti udah lihat pintas dari kampus ini kan? Nah, ini kampus 1, letaknya di Jalan Ganesha 1 Purwosari Kudus. Nah, kalian juga harus tahu, Umku juga punya kampus 2-nya loh. Letaknya nggak jauh dari sini, yaitu di Perabatan Lor, Jalan Kudus, Jepara.
Di sini, kalian tidak hanya belajar untuk mengasah ilmu pada bidang masing-masing, namun juga untuk merajut masa depan yang lebih pasti.
Betul, dengan pengajaran yang profesional, berpengalaman, serta ditunjang dengan fasilitas yang lengkap, kalian gak perlu ragu lagi untuk kuliah di sini.
Kak, kita bisa tahu lebih banyak lagi tentang Umku nggak, Kak?
Tentu dong, yuk kita lihat-lihat ke dalam.
UMKU memiliki 3 fakultas dengan 20 program studi, yaitu Fakultas Ilmu Kesehatan, S1 Keperawatan, S1 Farmasi, D3 Keperawatan, D3 Kebidanan, Profesi Nurse, Profesi Apoteker, S1 Kebidanan, Profesi Kebidanan, S1 Administrasi Rumah Sakit, D4 Teknik Laboratorium Medis, dan S1 Gizi.
Ada juga Fakultas Sains dan Teknologi loh, yang terdiri dari S1 Matematika, S1 Ilmu Komputer, S1 Sistem Informasi, dan S1 Teknik Industri. Yang terakhir, ada Fakultas Ekonomi, Pendidikan, dan Hukum, yang terdiri dari Prodi S1 Ekonomi Syariah, S1 PGSD, S1 Akuntansi, S1 Hukum, dan S1 Bisnis Digital. Bagi kalian yang belum tahu bagaimana laboratorium penunjang untuk praktikum di setiap prodi, di UMKU memiliki laboratorium farmasi, keperawatan, kebidanan, komputer, bahasa, dan lainnya. Kita sekarang berada di ruang serbaguna UMKU yang digunakan sebagai ruang pertemuan. Di sini memiliki fasilitas videotron, pengeras suara, dan ruangan yang ber-AC.
Universitas Muhammadiyah Kudus mendapatkan akreditasi dari Badan Akreditasi Nasional Perguruan Tinggi dengan predikat B.
Mempersiapkan masa depan kita, UMKU menjalin kerjasama baik di dalam maupun di luar negeri. Beberapa di antaranya, University Kebangsaan Malaysia, University Kuala Lumpur, Mahsa University, Dongseo University Korea, Wusuk University Korea, College of Pharmacy Taipei Medical University, College of Nursing Taipei Medical University, National Taipei Medical University of Nursing and Health Science, dan masih banyak lagi.
Universitas Muhammadiyah Kudus berkomitmen mewujudkan lulusan yang berakhlakul kalimah Islam, berwawasan global, dan memiliki kemandirian dalam berwirausaha. UMKU Self-Oriented Islamic University. Mari bergabung bersama kami di 20 program studi di Universitas Muhammadiyah Kudus.
Prestasi mahasiswa UMKU cek.
perusahaan siap mensupport prestasi mahasiswa dan kegiatan kemahasiswaan di Universitas Muhammadiyah Kudus.
Kak, selain bisa mengikuti perkuliahan, di sini kita bisa berkegiatan apa lagi nih?
Bisa dong, di UMKU kalian bisa berkegiatan dalam organisasi mahasiswa, yaitu di BEM dan IMM, serta unit kegiatan mahasiswa atau UKM lainnya. Di minat olahraga contohnya, ada tapak suci putra Muhammadiyah di bulu tangkis.
Dan untuk minat kesenian, ada teater, tari, serta paduan suara. Untuk minat khusus, ada KSR, Korps Sukarela, PMI, dan Kepanduan Hizbul Waton.
Oh iya guys, UMKU sekarang telah mempersiapkan gedung baru yang modern loh, tentunya dengan fasilitas-fasilitas yang lengkap.
Untuk menjawab tantangan zaman, Universitas Muhammadiyah Kudus senantiasa meningkatkan pelayanan kepada masyarakat dan publik. Salah satu upaya adalah dengan menambahkan sarana dan prasarana yang ada. Convention Hall, Kampus 2, dan Gedung 13 lantai untuk mendukung dan mewujudkan visi misi Universitas Muhammadiyah Kudus Global Entrepreneur Islam. Join with us.
Disinilah kami merajut masa depan yang terbaik. Universitas Muhammadiyah Kudus.
Speech from the Education and Culture Attaché on Embassy of the Republic of Indonesia in Manila to Professor Dr. Aisyah Endah Palupi, Master of Education. The floor is yours.
Waalaikumsalam warahmatullahi wabarakatuh.
Of Muhammadiyah Kudus, Bapak Rusnoto, and all faculty members, the respected speakers, Mr. Earl Francis from the Central Escolar University in Manila, Philippines, Ms. Tiffany Wang from the National Taipei University of Nursing and Health Science, Taiwan, Profesor Bisma Murti from Universitas 11 Maret, Indonesia, and Ibu Indana from Universitas Muhammadiyah Kudus. Good morning to each and everyone. I'm Aisyah Endah Palupi, representing the Ambassador of the Republic of Indonesia in Manila, Philippines. First and foremost, let us give thanks to the Almighty God for His blessings, guidance, and protection in these times of pandemic, so we may gather together virtually in good health. In this special occasion, it is my pleasure to be part and give message in this very memorable beginning to all of us. Today, the University of Muhammadiyah Kudus marked the milestone by conducting the first international webinar with the theme Stunting and Tuberculosis in Nursing Perspective in collaboration with the Centro Escolar University Manila in Philippines and National Taipei University of Nursing and Health Science in Taiwan and Universitas 11 Maret. And already to explain by Bapak Rektor is very complete explanation about the campus of the Universitas Muhammadiyah Kudus, and about the theme is stunting and tuberculosis. As we all know, it is not only of Philippines, Indonesia, and Taipei who are facing this pandemic COVID-19, but the entire world. Do these many problems and challenges arise, especially in the field of healthcare and education? Healthcare faces different issues day by day in order to sustain and maintain the needs of the people. While in the education field, all the classes from the basic education level until postgraduate are conducted via online learning. But this current situation in our field, it gives the chance and opportunity to the university to be creative on how to become a university that globally competitive, innovative to survive globally, have a good facilities and human resources that can match the needs globally. And even the biggest challenge in Indonesia is on how to encourage the students to participate in the program of independent study, independent campus that we call Merdeka Belajar Kampus Merdeka at the Mas Menteri program. Yes. By this change, I appreciate the courage of the University of Muhammadiyah Kudus who partake in this challenge, which to improve the quality of nursing Indonesia to tackle about the stunting and tuberculosis. This webinar is expected to enhance our knowledge, especially for nurses, in overcoming to treat of stunting and tuberculosis, which are currently a major health concern in many countries. As the new education and culture attaché of the Indonesian Embassy in Manila, Philippines, I will do my best to encourage and exchange cooperation in education between the Philippines and Indonesia, particularly in the fields of health and nursing. That's all I can share of all of you. I hope the first international webinar will be the foundation for our good and strong partnership from today. Again, thank you for the opportunity given and the attention. Maraming po sa inyong lahat. Terima kasih banyak. Thank you so much for all of you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you very much, Prof.
Yes, thank you so much Bapak Rektor. Salam hormat dari Manila, Bapak.
Alhamdulillah, terima kasih, sehat.
Well, ladies and gentlemen, we would like now to involve everyone to get a photo session together before the presentation is begun. So please, Ibu, to join a photo together with us. Please, I call Mr. Rusnoto as a rector and vice rector to join to the stage for the photo session. And dear all participants of this webinar in this class, also please join for the photo session together. Right? 1, 2, 3. Again. 1, 2, 3. Again. 1, 2, 3. Maybe freestyle. Freestyle, Ibu. 1, 2, 3. Okay. One more. 1, 2, 3. Okay. And thank you for the participant. And now please, right. Okay, we have still. One more time. 1, 2, 3. 1, 2, 3. Okay, freestyle now, please. 1, 2, 3. 1, 2, 3. Okay, thank you very much. Okay.
Ladies and gentlemen, those are the opening of International Webinar Series on Nursing at University of Muhammadiyah Kudus. That's all from me as Master of Ceremony. Let's close with saying Alhamdulillah. Alhamdulillahirabbil alamin. Billahi fi sabilil haq fastabiqul khairat. Assalamualaikum warahmatullahi wabarakatuh. Now we come to the main agenda of International Webinar Series on Nursing at University of Muhammadiyah Kudus, entitled Stunting and Tuberculosis, Nursing Perspective. This will be guided by Mr. Ahmad Nur Syafiq, Master of Education, as moderator. The floor is yours.
Thank you, Mr. Master of Ceremony. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Alhamdulillahirabbil alamin. Assalatu wassalamu ala rasulillahi ajma'in, amma ba'd. Let's praise to our Lord Allah Subhanahu wa ta'ala for His mercies and blessings. And our deep gratitude please be upon to our Prophet Muhammad sallallahu alaihi wasallam. Well, ladies and gentlemen, welcome to join in the first international webinar series on nursing today. So it's an honor for me to be here today. My name is Ahmad Nur Syafiq, and I'll be serving as the moderator for this webinar. In this international webinar belongs to the second event of international webinar series. After the last year we did successfully for the first event of international webinar series. Let's give applause together. One more time, I would like to say thank you to the superintendents of Taiwan International Healthcare Training Center for the collaboration and support for this webinar, and also Centro Escobar University in Manila, National Taipei University of Nursing and Health Science in Taiwan, and also Universitas 11 Maret Indonesia to support this conference also. Well, ladies and gentlemen, every single country in the world is now facing two kinds of pandemic right now, tuberculosis and also COVID-19, of course. People with COVID-19 and tuberculosis show similar symptoms, such as coughing, fever, and even difficulty in breathing. Another issue is that childhood malnutrition is a serious global health concern. Both of them can be a complex issue that makes up the main cause of a death and disease in the world. And that is going to be our interesting topic to discuss today, tuberculosis and stunting for a nursing perspective today. And now together with us, we have 4 expert speakers who will talk about this in a very deep today. And I will keep in touch with all speakers today. First, Mr. Earl Francis R. Sumil, PhD from Central Escola University. Hello, sir. Okay. Prof. Tiffany Wang from National Taipei University of Nursing and Health Science in Taiwan. And also Professor Bisma Murthy, PhD from Universitas 11 Maret, and Mrs. Indana, Master of Nursing, Pediatric Nurse Specialist, the Dean of Health Science Faculty of University of Muhammadiyah Kudus, Indonesia. So that's all 4 speakers that will explain about this topic today. And to save our time, so let's go directly to the first presentations. Maybe I will keep in touch first with the first speaker, Mr. Earl Francis. How are you today, sir? Hello?
Good morning.
Okay, good morning. Okay,
Thank you. I'm good, and I hope everybody is also doing well.
All right then. Okay, so it seems like we had connected with Mr. Earl Francis. Then before he delivered the wonderful presentation, so let me read his curriculum vitae first. Okay, so his full name is Earl Francis R. Sumil. His home address, P3L17, North Madison Place, Tikai, Malala City, 3000, Philippines. And I would like the philosophy hymn. It could be a wonderful thing. I am a professional who believes that nursing science should be utilized to improve people's lives by fostering collaborations among all disciplines and engaging active participations of communities. As an educator, my role is to act as catalyst for social transformation by journeying with the students in a process of learning and acquiring knowledge and skills to help others. Moreover, I see research as an opportunity to better understand social realities that shape both the landscape of the healthcare and the phenomenon of health. These, in effect, will charm community-based initiative that will advance health promotion and people empowerment. Oh, that was a really, really good philosophy. And I will tell her about the education. So he completed the PhD degree in nursing of University of Philippines, Manila, June 2018. And he completed the master degree of Mrs. of Art in nursing and with the predicate cum laude, of course, in the University of Santo Tomas, Manila, March 2008. And he completed for the bachelor degree in nursing also and cum laude, oh my God, at the University of Santo Tomas, Manila, April 2002. About his teaching experiences, so now he is a professorial lecturer, Centro Escolar University, Manila, June 2018 until now, till present. All right, and also he is an assistant professor of University of Santo Tomas, Manila, June 2004 until August 2020. And also international course faculty, Duke University, North Carolina, USA, August 2018. That was so great. And also, I'd like to read about the publication. There are so many publications, but I think it's a famous with 4, with the title Dengue Vaccines Controversy Awareness, and Vaccine Health Literacy, and Vaccine Accessibility Among Mothers in Select Rural Communities, and etc. About the program of research, so his content is about health promotion, primary health care, health equity, chronic lifestyle disease, health system, and community empowerment. So there are so many presentation and also professional things that I can mention one by one, and maybe to save our time. So now please let's go directly for the first presentation delivered by Mr. Earl Francis R. Sumil. Sir? So now the floor is yours.
Thank you, Mr. Moderator, for the kind introduction. Good morning and greetings from the Philippines. I am deeply honored with this invitation, so allow me to express my heartfelt gratitude to the organizers, to the University of Muhammadiyah there in Kudus. And allow me also to thank, at this point, the Dean of our School of Nursing here at Centro Escolar University for her trust, Dr. Urgel, and for allowing me to represent our country in this international webinar. Now, um, my task this morning is to share with you my perspectives about tuberculosis and malnutrition, specifically in terms of stunting. And at the same time, allow me to give everybody an overview of what we're supposed to accomplish in the next 40 minutes. So through this session, we hope, to revisit the biology and epidemiology of tuberculosis. And this will serve as our background to understand, why this topic is timely, particularly we're still struggling with the current pandemic. Second, we hope to describe the current situation of the tuberculosis pandemic, explain how tuberculosis, malnutrition, and stunting are related to each other, and hopefully, at the end, we can explore and enumerate collaborative interventions in the prevention of tuberculosis, specifically among us nurses. Now, to jumpstart our session, allow me to ask a few questions. And hopefully, this one will, number one, allow us to engage with one another. So please may I invite all of you to use your chat box, to answer. These are just 3 questions. So again, the pretest is meant for, facilitating engagement among all of our participants. Although it's virtual, it may not be, again, in person, but again, we want everybody to feel that we are together in this activity. So please use your chat box and write your responses. And second, the reason why we have this is, as I've mentioned, to jumpstart our session, and hopefully it stimulates our neurons to flood our synapses with neurotransmitters to keep our consciousness intact, that will sustain our attention all throughout this webinar. So, question number 1. Tuberculosis is more common among which of the following population groups? Is it among children? Is it among women? Is it among men? Or among older persons? Let me check our chat box. You can use again the chat box right away to respond, or simply reflect. Is it common among children, women, men, or elderly? The second question is that tuberculosis is spread in which of the following means? I know that this is a common knowledge already to people from Southeast Asia in our region. So considering that we're all part of the Southeast Asian community, I'm sure, we're all familiar with this. So let's just bring forth to our consciousness, how is tuberculosis spread in communities? Is it through respiratory droplet? Is it through physical contact? Is it airborne? Or is it vector-borne? And when we say it's vector-borne, is it through mosquitoes? It's a point for reflection. Third, and this is the last question, and hopefully we have stretched somehow and flexed, our cerebral prowess while reading through these questions. Now, this is probably the most significant question for our session, and we hope to answer this question later when we reach the end of my presentation. And that is, which of the following best describes how tuberculosis and malnutrition interact and intersect? Is it malnutrition results from TB infection? Is it malnutrition causing TB infection? Is it stunting causing TB infection? Or malnutrition increases the risk of TB infection and may result to stunting? So which of these statements do you think best captures how malnutrition, stunting, and tuberculosis are related to each other. Which means the question that should stick in our minds as of this point is it tuberculosis and malnutrition, okay, an association or a causation? And we'll answer that okay, at the end of the session. So, with the first objective, let's now look at okay, tuberculosis. What's the nature of this condition? Now, I'm sure, as I have mentioned earlier, that tuberculosis is a household term in our regional community. Philippines, Indonesia, and other countries, okay, around us, okay, are very much familiar, okay, into an endemic condition known as tuberculosis. And we know that this is an infection that primarily affects the lungs, and this is due to a microorganism named Mycobacterium tuberculosis. Now, it is transmitted, okay, through airborne, okay, and there is likelihood of spreading, okay, the infection faster in communities, particularly in closed spaces, and that includes households. Although tuberculosis primarily affects the respiratory system, it also affects other areas of the body, and that's the time we call it extrapulmonary tuberculosis. Now, apart from that, we know that tuberculosis infection comes in two forms. It can either be latent or it can be active. And what is alarming is that some of us, okay, may be having okay tuberculosis infection, but not necessarily exhibiting signs and symptoms. And this is what we call latent infection. Now, according to the World Health Organization, 1/3 of the global population are suffering from latent tuberculosis infection. And with that, we know that this contributes okay, to the public health crisis that we are into right now, considering that COVID-19, okay, as outlined earlier, has similarities, okay, with regards to tuberculosis. Now, when you talk about active tuberculosis, the person is already symptomatic and can spread, okay, the infection to communities. This means, okay, that clinically we expect that patients on active tuberculosis may present, okay, a syndrome, okay, of cough that may be lasting for more than 3 weeks. What else? The presence of hemoptysis. It can also be accompanied by fever, particularly late in the afternoon, associated also with night sweats. There's loss of appetite, okay, and with persistent coughing, may occasionally result to chest pain and loss of appetite. And ultimately, okay, we expect some sort of wasting or weight loss in the patient. Now, with this presentation, among children, it is more challenging to identify latent and active infection, considering that children may not necessarily identify that what they're experiencing heralds the presence of a disease. And another sad thing is that among children in particular, TB infection may affect growth and development. And that's precisely why we're devoting this international webinar in understanding how TB, nutrition, and stunting are all connected. Now, in terms of distribution, we know for a fact that tuberculosis is a global health problem. And according to the WHO, that tuberculosis remains to be a leading respiratory infection affecting particularly low-middle income countries. So shown on your screen, shown on our screen, okay, the map, highlighting that in the year 2017, the incidence of tuberculosis globally highest among areas belonging to low-middle income countries. And if I may direct everybody, and if I may invite all of you to look at the slide, particularly at the map, it is striking to note that those countries shaded darker are actually the countries that suffers from the highest burden of tuberculosis. And what is more alarming is that in our own region, in the Southeast Asian region, and that includes Indonesia and the Philippines, we have a big share of the burden of tuberculosis. Further, if we're going to look at this map, countries like the Philippines, Indonesia, okay, what else? Countries, okay, in the sub-Saharan region of Africa suffer the highest burden, including India, from tuberculosis. And we know that these are countries that are part of low middle income category. And the distribution of tuberculosis is a clear expression of health inequity, which means there's disparity in health outcomes depending on where you live. And this is a testament to what we call the social determinants of health. So we can aptly say, as early as now, that tuberculosis is closely linked to social determinants of health. Now, based on the World Health Organization's Global Tuberculosis Report in the year 2020, it is estimated that around 10 million people were infected with tuberculosis. So this is pre-pandemic figures. And considering that these figures are pre-pandemic, may I ask, you can use your chat box, by the way, if you want to share your thoughts on this. What do you think now is the number of cases of tuberculosis at this time of the pandemic? Do you think cases have increased, or have decreased? But both are possibilities. Can be, can be increased, can be decreased. Decrease in the sense that with quarantine, there's limited interaction among people in certain communities. However, it is also a possibility that with the quarantine, transmission can happen at the level of families in our own households. So figures, will prove that when all the information and data through research is out by probably the next few months. Now, let me go back. In terms of the Global Tuberculosis Report of 2020, it was also mentioned, that men accounts for 56% of most cases of tuberculosis in the year 2019. And that answers already two of our questions in our pre-test. Now, women accounts for only 32%, and the smallest percentage of tuberculosis cases affects children, and that is placed at 12%. Now, given again these figures, then you may be asking, so why do we need to talk about malnutrition, and tuberculosis among children, in this international webinar? It's because with children representing only 12% of cases, children will suffer the biggest blow, in terms of future disability that may happen brought about by tuberculosis, increasing demands for energy and worsening outcomes on health together with malnutrition. So we'll talk more of how these factors interact and intersect in the next few minutes. For now, may I also share that based on the WHO report that people living with HIV, as mentioned by the good rector of the university earlier, significantly accounts for a big number of people suffering from tuberculosis. So we see that based on global report that an immunocompromised status, such as having HIV, increases the risk of developing infection. And when I talk later on of our own context here in the Philippines, I'll point out again what specific populations or population groups are of interest in our public health scenario, because there are clusters of cases in our country with tuberculosis. But for now, it was also stated, let me go back again to the Global Tuberculosis Report of 2020, that 4 countries were identified to have the highest burden of tuberculosis in 2019. And that includes India, South Africa, Indonesia, and the Philippines. So talking about our country, from our point of view, tuberculosis remains to be a public health menace. And shown on the screen, based on our Department of Health figures, that over the last 8 years, we're still struggling with tuberculosis. In spite of advances in healthcare, in spite of advances in research and development efforts, the cases of tuberculosis continues to rise. So the question here is, if the cases of tuberculosis remains high, what happened now to our global commitments, okay, to end tuberculosis, specifically in 2035? With this type of trend, maybe that global, okay, target may be far from being reached. So I hope that in the course of our sharing this morning, we'll look into, is it likely that nutrition has a role to play in why we've not been successful in eradicating or at least controlling tuberculosis in our respective communities? Moreover, as I've mentioned, apart from the Philippines struggling with the growing trend of tuberculosis over the last 8 years, it remains to be the leading cause of infection that brings about death among my compatriots. And in 2018, the WHO took note that around 26,600 Filipinos died from tuberculosis. And this is such an alarming number, considering that the figures are pre-pandemic. And number two, we have already an established program and protocol in the treatment of tuberculosis, because we all know that tuberculosis is an infection that can be treated and can be prevented. So one death is, one too many already. So having 26,600 people dying, okay, from this condition is definitely a cause for alarm. Now, let me share with you our latest, okay, statistics with regards to mortality among Filipinos. So on your screen, okay, friends, is the 2021 mortality rate in the Philippines. And here is a comparison, okay, of 2019 and 2020 cases. 2019 and 2020, correct. So here's a comparison of 2019 and 2020 cases. And as you can see, consistent with the global trend, the Philippines, okay, has non-communicable diseases as the major cause of death. Like on top of the list, we have ischemic heart disease, and we know that this is your heart attack, your coronary artery problem, chest pain, angina. Cancer is ranked number 2. Cerebrovascular diseases is ranked at number 3. And this includes stroke. And then we have diabetes, we have pneumonia, we have hypertension, coronavirus disease, okay, because of 2020. And then we have respiratory tuberculosis. Now, is it likely that non-communicable diseases labeled as comorbidity may contribute to the likelihood of people getting infected, okay, with tuberculosis in the same manner that we have already established as far as the current pandemic is concerned? Okay, that tuberculosis can also easily infect people with comorbidities. We'll answer that later. Okay, so here, by the way, is our latest statistics. But again, what is sad to note in these figures is that most of these conditions are actually preventable, and therefore we may consider that these deaths are unnecessary only if our country, the global community, commits to health equity. Now, based on studies, checking on systematic reviews and established evidences, what risk factors, particularly among Filipinos, from our perspective, strongly connected to the development of tuberculosis in our population? Sex and gender, okay, is on top of the list. And this is consistent also with global trends that I have shared earlier, that it's more common among men. And if you're asking, how come men has the bigger share of the cases of tuberculosis, it can be related to the factor of smoking. It's because in terms of the global adult tobacco survey, most smokers, okay, or men, okay, are likely to smoke, okay, likely to consume tobacco compared to women. And that accounts for the reason why men has the biggest share and therefore considered as a risk factor for the development of tuberculosis. Age is another. And in terms of age, we've seen based on the World Tobacco or the Global Tobacco Report that children has the smallest share. So the number of cases of tuberculosis and the risk of developing tuberculosis goes up with age. And when we say it goes up with age, it is likely to infect people above 15 years of age. Comorbidity is another. And this is where, okay, our topic about malnutrition is strongly correlated, considering that in terms of comorbidities, diabetes is closely linked. Okay, there are several studies supporting, okay, that diabetes increases the likelihood of developing tuberculosis. Okay, and this is attributed to the effect of diabetes, the effect of a high blood sugar to our immune response. And that's also the reason why, okay, our topic is about malnutrition and tuberculosis and how they interact. It's because we know, okay, as early as now, that diabetes impacts nutrition because it has something to do with the diet. Poverty is one, and considering poverty, we expect that people tends to move from rural areas to urban areas. So living in cities where there is a high population density may further contribute to your risk of developing, okay, tuberculosis. Now, in terms of age distribution, the Philippines, okay, shares the global trend that the highest incidence and prevalence of tuberculosis is among, okay, people above 14 years of age, which means 15 and above. And as you can see, in terms of distribution, okay, there are more males again suffering, okay, from tuberculosis compared to females. Again, consistent with WHO, again, findings. Now, what about TB and malnutrition? According to the World Health Organization, in the year 2017, there are around 815 million people who are suffering from undernutrition, and this is not limited to children. So, it is also stated that in the year 2018, malnutrition, undernutrition actually accounts for twice the number of cases of tuberculosis compared to HIV, which, okay, is something striking considering that our assumption is that understanding the biology of the human body, that when someone is immunocompromised, okay, you have a higher chance of developing infection like tuberculosis. But in the year 2018, the WHO pointed out that actually it's undernutrition accounting for twice the number of the cases of tuberculosis globally, which means, okay, there is a strong association between undernutrition, malnutrition, with regards to tuberculosis infection and the possible outcomes of the disease. Now, when we talk about malnutrition, in the course of our discussion, we are referring to malnutrition in three forms. It can be in the form of stunting, it can be in the form of wasting or overweight. Now, specifically among children, okay, take note, okay, that malnutrition is highly prevalent in the form of stunting. And when you talk about stunting, okay, we refer specifically to stunting using the lens of the World Health Organization as referring to children, okay, too short for their age. So we're seeing, okay, that malnutrition takes different forms. However, in our webinar, okay, we're specifically understanding malnutrition, okay, referring to stunting. Now, in terms of global trend, the good rector has already mentioned this earlier, and I'm happy at least there's synergy in what we're doing this morning, is that the prevalence of malnutrition has gone down over the years. However, even with the decline in the figures, and this is taken from the UNICEF, okay, report, although the numbers have declined, it remains to be a major concern, and our fight against malnutrition remains significant as ever as before, particularly in the light of emerging infectious disease. And that includes, of course, the current pandemic and, of course, tuberculosis, because it remains to be a significant public health threat. Now, the question of how, by the way, is tuberculosis, malnutrition, and stunting are all related. So let me now cite with you again, the results of what I did. Okay, so this is a form of again review of literature that I did. And I use, by the way, two search platforms. I use Google Scholar and I use PubMed, and check for articles from 2010 onwards, and to look into the association of tuberculosis, malnutrition, and stunting. And although there were several articles about showing the relationship of malnutrition and tuberculosis among all age groups, specifically among children, there seems to be plausible information. There's scarcity, of evidence that will support, causation. But what is established is that they are associated. Now, particularly of interest or discussion is that in terms of the figures that I shared, 815 million people were undernourished in 2017, and more than half of these numbers are located or are living in low middle income countries, and that includes my country, the Philippines. And if you're going to look at these figures, countries with the highest number of malnutrition, are also the countries that has the highest burden of tuberculosis. And there seems to be a link between malnutrition and tuberculosis that would support, our assumption, that there is an association between tuberculosis and malnutrition. And as I have mentioned, in terms of evidence, instead of causation, it is an association, because malnutrition can be a risk factor. Malnutrition can affect outcomes. Now, sir, how does this happen? It's because when we know that infection sets in, like tuberculosis, the need, by the way, to respond, to the infection by limiting it, to the point of entry, is carried out by our immune system. So what therefore is important to help us predict the prognosis of a person suffering from tuberculosis is what we call our adaptive response to infection, our immunocompetence. So immunocompetence, therefore, is crucial, in helping people recover, from tuberculosis, or if not recover, resist the likelihood of getting infected from tuberculosis. And this is where, malnutrition and TB are, interacting. It's because with malnutrition and undernutrition, it was already established, through evidence that malnutrition lowers our cellular immune response. It lowers our immune defenses. And this, by the way, increases our vulnerability, to tuberculosis. And, complicates the outcomes, of tuberculosis, meaning the likelihood of recovery or mortality. Now, according to Martin in 2018, although there is a relationship, I have said earlier that establishing its causation remains scarce. So there's a need to explore, and look into other factors, that accounts for such phenomena. Now, further, when we talk about TB and malnutrition, what is clear as of the moment is that malnutrition, undernutrition, lowers our immune response. And this can be attributed, to specific nutrients. And based on evidence, it's not limited to macronutrients. It includes micronutrients, in particular vitamins A, D, C, iron, and zinc, which are, based on studies, are important factors that support cellular mediated immunity. Now, people therefore with malnutrition are likely to have a struggle in recovering from tuberculosis. Now, among children in particular, this is of interest. It's because we know that the first 5 years of life accounts for a period of growth and development. So metabolism at this point is increased, and the demand for nourishment, is likewise increased. So in the presence of, malnutrition, when the demand, when the demand exceeds the supply, or if the supply is not enough to satisfy the demands of the body, that results to malnutrition. And so with this, we expect, that the presence of infection will further exacerbate the presence of TB infection among children, will further widen the gap, of the nutritional requirements to fuel growth and development. And that is where okay, stunting is in the picture, which means, okay, with the presence of tuberculosis, increasing metabolic demands, affecting children who has a higher metabolic demand to support growth and development. Okay, there's what we call that gap, okay, because there is a deficit, okay, and the result is that the child cannot fully optimize growth and development and results to stunting. Now, as I have mentioned, not limited to micronutrients, macronutrients are also established to be linked, okay, to tuberculosis. And this includes protein energy malnutrition in the form of kwashiorkor and marasmus. And if I may point out that according to again, on Bubalili as early as 1988. So this is the historical data that in terms of the level of protein in the body, this protein energy malnutrition, okay, worsens the possibility of children recovering from tuberculosis and makes them more vulnerable. Now, in more recent findings, particularly in laboratory studies, indeed, a drop in the level of proteins in the body increases the susceptibility to mycobacterium infection. Now, at the same time, okay, several studies underscored, okay, the role of anemia, particularly iron deficiency anemia and tuberculosis. And we know that iron deficiency anemia is rampant, okay, in low middle income countries. So speaking from our perspective here in the Philippines, okay, iron deficiency anemia is a leading micronutrient disorder. And the presentation of iron deficiency anemia of a child who is lethargic, a child who is weak, a child who has lack of energy, a child who may be exhibiting pallor, are somehow, okay, similar to the presentation of people suffering from tuberculosis. And it complicates, okay, the problem. Okay, for that reason, okay, it is important that with all of these evidence, that we look into how we can integrate nutrition in our public health interventions in preventing and controlling tuberculosis in our communities. Hence, okay, with all of this evidence, okay, the call to action is clear that stunting and malnutrition, okay, are risk factors, affects outcomes of again tuberculosis, and may potentially affect even efficacy of vaccines. We all know that BCG vaccines, okay, are deployed as part of our routine immunization, okay, to prevent infection. But in the presence of malnutrition, studies have shown also that it reduces efficacy of these vaccines. Hence, okay, what is important is that we look into how we can incorporate nutritional strategies in our public health interventions. So in conclusion, okay, TB and malnutrition and stunting among children are closely linked to each other. And it is quite clear in terms of, number one, okay, clinical presentation, which I have explained, because both malnutrition among children and tuberculosis may have overlapping signs and symptoms, and this is where the problem lies. Second, in terms of outcomes, so mortality, okay, is increased in the presence of malnutrition among children with tuberculosis and across all age groups. Now, further, if I may quote Hirana in 2021, this is a more recent study. They were able to identify, okay, that the predictors, okay, of tuberculosis in our communities include, number one, stunted nutritional status, particularly moderate and severe. Hence, in our communities, surveillance, early detection strategies must be incorporated. In terms of gender, okay, boys, meaning children, okay, are likely to develop tuberculosis in households. Okay, another predictor is that lack of immunization, obviously, and of course, high contact intensity. And when you say high contact intensity, if children are living in communities where tuberculosis cases are rampant, that increases the risk. So with all of these, the challenge to us nurses, okay, is to, number one, okay, we need, by the way, to develop advocacies. What can we do, okay, as of the moment? I know that the pandemic has limited our mobility, okay, but we can make use of our virtual platforms in order to influence our immediate spheres. And when we say immediate spheres, we're talking about your friends. For example, if you have social media accounts like Facebook, share information about how tuberculosis, okay, can affect people who are undernourished. Okay, go for advocacies. Okay, to help, by the way, engage communities at the same time. Establish virtual groups among your peers in your respective villages. Okay, so that you can talk more, share more, okay, about the nature of tuberculosis. And this is not limited to children. Okay, you can target, by the way, adults with comorbidities. We know that they are the ones who are at a higher risk also for COVID-19. But let us not downplay the possibility that with COVID-19, okay, and tuberculosis, the risk for mortality is much, much higher, okay, compared to other population groups. And of course, we need to intensify health education campaign. However, it was stated, okay, in several studies that counseling, dietary counseling, okay, teaching people about the right nutrition is not enough. And this is where I would like to invite everybody to go back to the map that I've shown earlier today. And isn't it the global map where the highest burden of tuberculosis, okay, lies among, okay, befalls among low middle income countries like ours, is that it's not enough that we teach people what to eat, okay, in order to help strengthen their immune response in fighting infection. We need, by the way, a whole of society approach in ensuring that sanitation is maintained. Okay, we have social services, okay, that can support, by the way, better living conditions, including education, employment. Let's all aspire for an inclusive development, because healthcare without, okay, understanding social determinants, okay, will not be enough. So it is high time that we mainstream the idea that as healthcare professionals, particularly as nurses, we need, by the way, to develop a frame of mind in which we need not to be expert clinicians. In order to improve health outcomes, we need to go, on field work. Each one, teach one. We invest in educating communities about how all of these factors, employment, education, sanitation, hygiene, water, food, influences health. That's why I always tell my students when we do our clinicals, okay, how come, okay, the cases of tuberculosis in the country remains high? And there's clustering among people living with HIV. There's clustering among our people deprived of liberty, which means we've seen cases of tuberculosis soaring high in our prison facilities. So I always tell them, is taking rifampicin, isoniazid, pyrazinamide, okay, is using multi-drug therapy, okay, enough to cure tuberculosis? I think the answer is quite clear. It's not. Because in spite of all of this technology that we have, cases are still on the rise. It's because we failed to include in the picture that the treatment, okay, of tuberculosis, preventing tuberculosis, okay, requires an understanding of all of these social determinants. And I hope as nurses, okay, we get to embrace that role, okay, of advocating, okay, engaging stakeholders, like talking to decision makers, okay, for them to invest, okay, on good nutrition, okay, integrate nutritional programs, okay, in order, okay, to strengthen immune response and therefore reduce, okay, the cases of tuberculosis in our communities. So with that, I wish to thank everybody, okay, for listening to what I've shared. And these are my references, and you can check, by the way, these references to help you again in your further study. And these are the sources of the images I use for this presentation. So again, thank you so much. And from the Philippines, mabuhay at maraming salamat.
Thank you, Mr. Il, for wonderful presentation today. And I think we still have so many discussion after this. Okay, to be more comprehensive for the presentation from Mr. Il Francis, now I'd like to invite all webinar participants to join for the discussion or question and answer session. So if you have any question, now please raise your hand, and then also you can create your questions in our chat room. And also please, if you have question, also you can go directly for turning on your microphone. We are available for that. So now I invite all participants, please, if you have any questions, now you can have your question. So maybe from the chat room, if we have any, please now show the question, please. All right, well, ladies and gentlemen, if you have any questions, the webinar participant, you can ask directly to Mr. Il for wonderful presentation today. Is there any? Yes? Okay, so seems there is one question, sir.
Go ahead. Now, in the event that our participants have no questions, they can send me an email. Okay,
Of course. Yes, of course, sir.
If they can send me an email for questions, and I'll gladly share the references that I shared to everybody.
Okay, to those who are not ready for the questions, maybe you can send the email directly to Mr. Il. Okay? So one participant?
Okay, Mr. Safik, I have questions for Mr. Francisco.
Okay, go on, sir.
Yeah, hello, Mr. Francisco.
Hello, Awari.
Good morning.
Good morning.
Okay, I have some questions for you. If you are talking about TB, tuberculosis disease, drastic to learn and understanding. In TB has now with ISTC, International Standard of TB Care. It is a standard in how it should be treated by a doctor or health service. This is my questions. ISTC has 17 standard. 6 standard is about how is TB diagnosis, and then 9 standard is how TB treat, and then 2 standard is responsible from the doctor. And then I need the explanation about these standard and how to solve this problem, and then how to understand, because from from health department, how to solve this problem if someone understand, for instance, or examples, we are living in the current village, like mother and father yeah, I'm education, right? I understand. How about someone like that? Thank you, Mr. Francisco.
Thank you, Anwari, for that wonderful question. I think it is important that as nurses or as healthcare professionals in general, we need to translate standards to our patients, particularly in communities. When we say transform, translate, it means we need to ensure that these standards don't remain as standards that guides clinicians like doctors, nurses, from doing from doing specific tasks in the detection, screening, and treatment of patients with tuberculosis. But rather, it is important that nurses should engage again communities. Based on the evidences that I shared earlier, it was clear, that nutrition has not been given much emphasis in the treatment, control, and prevention of tuberculosis. We have invested so much on diagnostic technology, like the use of, again, sputum smear microscopy, the use of what we call gene expert, the use of even sputum culture, x-rays, and the like. But we have also to what else? Apart from diagnostic, again, technology, we have invested a lot. Our public health system has invested a lot on the use of pharmacotherapy, and that's the use of what we call extensive drugs like rifampicin, isoniazid. However, the understanding of how all of these standards, the screening, the detection, the diagnosis, and treatment, limited, to health professionals. So the question here is, I think we can be more successful if we're going, by the way, to translate the standards, of detection and cure, to communities, by focusing on the promotive and preventive aspects of care. And as I have mentioned also earlier, is taking, for example, your combination drug of rifampicin, isoniazid, and pyrazinamide, and patients. Because I am an independent community practitioner here in our province. What we notice among, again, our patients is that there are patients, who keeps on coming back. Like after a year, we see them again on the clinic. And the problem is, even if they have, they have completed the 6 months to 9 months regimen, they're still suffering from tuberculosis. It's because of they're living in areas where there is congestion, there is poor sanitation. What else? When they come, they're presenting signs of wasting, kakeksha, and it's again a proof that the social determinants of health is an issue. Like they are unemployed, they have poor access, therefore, to nutritious food. So even if we tell them they take the medicine, studies have shown earlier that poor nutrition affects the efficacy, not just of vaccines but even anti-tubercular drugs. It's because, if I may also point out that with undernutrition present or malnutrition present, it affects the abilities of our liver to metabolize drugs. And with the limited ability of the liver to metabolize drugs, then it means the efficacy of anti-tubercular therapy and the likelihood, therefore, of hepatotoxicity is there, which means with hepatotoxicity present, then it might interrupt the course of treatment of tuberculosis. And this will again affect the likelihood of recovery. So again, I'll go back, in conclusion, I'll go back. Although we have standards, it's not enough because standards will remain as standards to guide the actions of health professionals. We need, to engage communities. We need, by the way, to talk to people, tell them about tuberculosis cannot be prevented alone, through, a wearing of masks. We need, by the way, better living conditions, and we need to hold people, in government who are decision makers, about the current state of our communities. Thank you.
Okay, thank you, sir, for the wonderful explanation and answer. And to Mr. Anwari as a questioner, does it answer the question? Hello? Yeah, maybe the question is answered quite well. Okay, sir, maybe we have still more questions through the chat room. So everyone, please, can I get the question from the chat room? Okay, so next question, sir, from the chat room question. The question from Muhammad Johar. Thank you for your material. I am Jojo from Nursing Department of Universitas Muhammadiyah Kudus. Nice to meet you, Mr. Agil. I'd like to ask, maybe you can explain to us about tuberculosis and stunting management community based in Philippines. Start from early detection until the program evaluation. Maybe can be input to us so we can adopt that model in our country. Thank you very much before. Okay.
Thank you, Muhammad. As I have explained, in our country, why we are not successful in controlling the cases of tuberculosis is that our approach is we call this. Our approach to the management of tuberculosis is actually fragmented. And when we say it's fragmented, instead of combining, by the way, nutrition, counseling, okay, in the management of tuberculosis, we are focusing more on detection and treatment, which means in the Philippines, our approach is highly clinical. And when we say it's highly clinical, we focus on identifying who are suspects based on presentation, who are contacts, and then we submit them to sputum testing, and then once it's confirmed, we start them with the regimen. That's it. So there's no support in terms of nutrition. There's no counseling about there's no program for counseling about what micronutrients are crucial. Okay, but rather again, it's more on dispensing the treatment. That's it. So I mentioned earlier that what we can do. That's why we are lobbying. So we are lobbying, by the way, our decision makers. Okay, so there are several groups right now in the country that is, talking to people from our Ministry of Health and even local government units to come up with innovative strategies. And when we say innovative strategies, it means although it may not be funded nationally, okay, we can start small-scale projects of integrating nutrition in the management and treatment of tuberculosis. Now, with regards to nutrition, okay, the program for nutrition for Filipinos are limited to children. So if we're talking about stunting, okay, we have an established program on micronutrient supplementation, in which, again, children under 5 years of age are given supplements of vitamin A and iron. However, this is outside of the context of managing tuberculosis. So if, for example, children came in, okay, to a primary care facility, and the problem is malnutrition, it will be treated as malnutrition. However, if in the course of admitting the child, okay, he was found to be a case of active tuberculosis, then side by side with the supplementation will be the treatment, okay, for tuberculosis will be started. So as you can see, the gap that we have, okay, is really a fragmented approach. So what we need, okay, is an integrated approach of combining, by the way, nutrition, okay, and TB treatment among children. Because again, with stunting, okay, among children, the recovery, okay, the trajectory, okay, is quite poor, and it may increase mortality at the same time. So again, we need to combine both. Now, I saw already take the liberty to answer the questions directly. So there was also a question about immunization, about BCG. Is it still possible, okay, that children who were immunized with BCG can develop tuberculosis? Yes. there is again the possibility. So if we're going to look at evidence, there are several documented cases of people who may have received the vaccine but ended up developing tuberculosis. It's because um, um, there are an interplay of variables. At the time of immunization, maybe nutrition, okay, may be poor, and that weakens the efficacy of attenuated vaccines. Because there's a study about, again, the role of cytokines inflammation, okay, due to malnutrition, and this directly influences efficacy of, again, BCG vaccines. And following the same biology, okay, and mechanisms that I have just explained, that's also one of the reasons why we keep on campaigning in our communities. Okay, I'm active on campaigning here in our communities. That even if you're vaccinated against COVID-19, okay, the likelihood of developing COVID-19 is still there. So we need to adhere to minimum public health standards of wearing a face mask, frequent hand washing, and then physical distancing. Okay, so if the other question is, okay, let's answer again the question. So is it stunting causing TB?
Yeah.
Or is it TB causing stunting?
Yeah.
Okay, the answer to that question,
Yeah, okay.
is not as
So-
simple as yes or no.
Yes, sir.
But
Let me read. Okay, sir. Let me read another
Go ahead.
question. But thank you for the explanations, for wonderful explanations of the question. And to the questioner, Mr. Jauhar, does it answer the question? Okay, hopefully, yeah. Right. So move to the next questions. Please show the question. The question from Ibu Nur Khalif. Good morning, Mr. Franz. I am Khalif. I would like to ask, how is the initial treatment or when the TB movement? So the question is, okay. Okay, so yeah, okay. Okay, from Ibu Nur Khalifa. So the question is, okay. So, let me repeat one question from Ibu Nur Khalifa, sir. Good morning, Mr. Fran. I am Khalif. Please ask, how is the initial treatment or when a TB patient is diagnosed with the COVID-19? Okay, so that's the question, sir.
Yeah, I think to answer that, let me first ask, is the COVID-19 mild? Is it moderate or severe? So in our experience here in the Philippines, usually when people, by the way, are admitted to our hospitals and their presentation is difficulty of breathing, and then they have high fever, which is typical of COVID-19, we consider them as a suspect. So, and the treatment is directed to support the signs and symptoms. So between COVID-19 and tuberculosis, the initial treatment will focus on relieving the signs and symptoms of COVID-19 rather than tuberculosis. It's because, again, considering the acute nature of COVID-19 and its complications, the likelihood of the person dying from COVID-19, okay, is higher than that of tuberculosis. So we initially manage the COVID-19. And then once the patient's stable, and when it was also confirmed that the patient also has tuberculosis, then it will have to be it will be treated, okay, but this time outpatient. So it will be community-based treatment. So in-facility treatment will focus on relieving COVID-19. Like, again, what constitutes the COVID-19 treatment initially would be respiratory support, ventilatory support.
Okay, thank you, sir. To Ibu Nur Khalifa, hopefully it can answer your questions. And I will move to another question. The question from Ibu Ana Fadila. The question is there a responsibility after getting BCG vaccine? Can the child still get the disease? So, is there possibility after getting BCG vaccine, the children can get TB disease, sir? So that's the questions.
Thank you. I think I have answered that earlier. So I'm so sorry. I took the liberty already of answering that previously. But yes, the possibility is there. But how many percent is the possibility of a child who has received BCG infection from getting the infection? Again, depends on a variety of factors. It can be at what age the child is. It can be the current nutritional state of the child, okay, and the presence of comorbidity. So these factors will determine the possibility of having. And one more thing, we need to draw the line whether it's latent infection or active infection. Now, as far as experience is concerned, for children who's received BCG vaccine, it's more of latent infection. Okay. Now, what's the good thing about latent infection of tuberculosis is that it's not transmissible. Okay, and it's the active form. Okay, that may contribute to its spread.
Okay. Seems like we have still one or two questions more, sir. And then the question is, please host the question. Okay. So the question from Ibu Ika. Mister, which one is true? Stunting causes TB or TB causes stunting? And how? Thank you. So that's the question, sir.
Oh, I think that's the last question. So thank you. Again, as I was about to answer that earlier, and I've stated that the question of is TB again causing stunting or stunting causes TB cannot be simply answered by an absolute yes or an absolute no, because both are true. Children with malnutrition and has stunting has a higher risk of acquiring tuberculosis. However, evidence that is limited, okay, to show direct causation. So association, yes. So if the child has malnutrition and has stunting, the risk of developing tuberculosis is higher. Now, for a child, okay, for a child who has no stunting but has developed tuberculosis, okay, the likelihood of developing malnutrition and stunting, okay, after TB infection or due to TB infection is also there. Why? Because as I have explained with the evidence I shared, that the demand for energy and micro and macronutrients increases, okay, during infection, like when the body is battling tuberculosis. And since children, by their age, okay, demands more nutrients because of growth and development, then this brings about what we call an imbalance between supply and demand. So the likelihood of the child suffering from stunting due to, okay, the impact of tuberculosis is also expected. So the answer is both.
Okay, so that is a really wonderful explanation. Okay, so to the questioner, Ibu Ika, hopefully it can answer your question. And seems like we have still one more question, sir. Is that okay? Okay, so please, so okay, so the question, please. The question is, please. Finish. Okay. Okay, sir. Hopefully, we close this discussion for the first. And thank you very much, sir. This is a really wonderful explanation, Mr. Earl. And before the presentation is done, so I'd like you to please give your closing statement, sir, for your presentation, please.
I would like again to thank the organizers for this opportunity to be part of your international webinar on tuberculosis and stunting. And I hope that our participants will embrace their role as agents of community empowerment and take the role of an advocate, okay, to mainstream the idea of the social determinants, okay, that health cannot be contained in a pill, but we need, by the way, to work hand in hand with all stakeholders in making health a reality and making health truly in our own hands. So thank you so much.
All right then. Thank you very much, sir. One more time, give applause virtually. to Mr. Il. Sir, before we end this session, we would like to invite to a photo session together with our rector, sir. So I welcome to state Mr. Rusnoto as the rector and also vice rector to join to the stage for the photo session together. And please now all webinar participants to stay on your camera, please. Together photo session for the first session. Okay. Okay. 1, 2, 3. One more. 1, 2, 3. Okay, freestyle now, Mr. Il. You can have your freestyle. Okay. 1, 2, 3. 1, 2, 3. So after this, we are going to listen together the video profile from Superintendent from Taiwan International Healthcare Training Center.
Hello everyone, this is Dr. Harsh Jakheria from India. Last year I joined Taiwan International Healthcare Training Center's Dermatopathology Training Program. Wanna see how my life is like in Taiwan? Let's get going. This is our training lab. Let's go. Hello. Good morning. My clinical training consists of routine sign-outs, weekly review of typical and atypical cases on Wednesdays, clinico-pathological conferences on every Thursday, immunofluorescence and electron microscopy reporting, learning from archived slides and cases, and monthly self-assessment and topic tests. Dr. Wu is a great mentor and great teacher. If you have interest in dermatopathology, I would definitely recommend this program.
The level of medical service in Taiwan I think it's outstanding. It's very amazing. We also have many medical centers and provide advanced medical care. For the students or the scholars, we have a very good subspecialty training or specialty trainings. For the training of dermatopathology, this is a very subspecialty. Not many training centers can do this job. There is an international committee for dermatopathology. They will accredit the training center in the world. There's only 2 sites in Asia. The site in Taipei, our program is the first accredited program for this ICDP. This is also a major site of Asian Society of Dermatopathology. And I'm the current president of ASD, and we will provide many teaching resources. So if you come to our programs, hope that can help in your future career. Those are from the sales. Oh, it's lunchtime. Lunch. Good break.
I love Taiwanese food so much. Taiwan breakfast restaurants are pretty common and they would be open from early morning till afternoon. I got my choy open. Yay. TISTC is just like my family in Taiwan. We always have fun and celebrate all the special days together. We make rice dumplings during the Dragon Boat Festival. We twerk and dance at the year-end party. We celebrate the Christmas and open the gifts together. We have birthday parties every now and then. Everyone stay safe, stay happy and stay healthy. Thanks to TIHTC, I have experienced almost every aspect of the Taiwanese culture. I would really like to thank TIHTC for giving me such an indelible training experience. Not only do they have a wonderful dorm room, which makes me feel at home, but they also help me find the best hospital for my clinical training. Everything I've learned during my training would be conducive to the reinforcement of my profession.
Congratulations
Thank you.
on your learning in Taiwan.
Thank you. Thanks a lot. I love Taiwan. I love TIHTC. Your first choice of clinical training platform.
Now we come to the second session, the presentation from Professor Tiffany Wang. So let me keep in touch with the professor first. Hello, Professor.
Hey.
Okay, so have been connected with us, right? So, okay, Professor, before you deliver your wonderful presentation today, so we would like to invite a photo session first. And I invite all rector and vice rector to come to stage to get a photo session together, please. Okay, Professor, we are now ready for the photo session. So we have four style now. For the first style, please. Okay, for the formal style. 1, 2, 3. Again, 1, 2, 3. For the second style, please, Tom, show the time. Show your time. Okay. 1, 2, 3. Again, 1, 2, 3. Okay. And then the third style is freestyle, Professor. So freestyle. 1, 2, 3. 1, 2, 3. Okay. And then the last style is okay, bringing go.
My certification.
Okay, right, Professor. Okay, okay.
Can you see clearly? Yeah.
Yep, this one. Okay.
This one.
One, two, three. 1, 2, 3. Okay. Now, please, everyone join, please, for the webinar participants to join for the session with the bringing local. Okay. Okay. 1, 2, 3. For the last one, so for the session with no must. Okay. 1, 2, 3. 1, 2, 3. Okay. Thank you very much, sir. Okay. Thank you, Mr. Rusnata. Right now, so we come to the second session of the presentation, and then now we have Professor Tivani. How are you there, Professor?
Hi, how are you?
Fine, at home. Okay, so Professor Tivani today would like to talk about COVID-19 assessment and management. So she prepares for the wonderful presentation today, but before she deliver the wonderful presentations, allow me to read her curriculum vitae first. Her full name is, if I'm not mistaken, spelling T-Z Tivani Wang. Okay, and for the website, National Taipei University of Nursing and Health Science. About her education, right, in 2018, University of Washington settled for the visiting scholar. 2000 till 2004, University of Washington settled for PhD nursing science, and then 2001 till 2003, biomedical nursing research. She also joined the training settles for the pre-doctoral training in 1993 to 1995, University of Utah Salt Lake City, MSN Adult Nursing, and 1983 through 1987, National Defense Medical Center Taipei. And about the specialist and research interest, so she is really interested in chronic disease self-management, symptoms management, lifestyle intervention, health promotion for cancer, survivorship, adult nursing, and critical care nursing. About the professional and academic memberships, in 1987, Present Taiwan Nurse Association. In 1987 also, Present Taipei Nurse Association. And Present Stigma Theta Tau International Honor Society of Nursing, and etc. There are so many honor and fellowships that I can mention one by one. And about the research project, there are so many research projects that she had done, but at least I could not mention one by one. But she founded research project with titled Efficacy of an Interactive Web-Based Self-Management Support Intervention on Health Outcome in Patients with Colorectal Cancer. This is a mixed method study, and also she is very familiar with the developing and testing a self-management support intervention and colorectal cancer survivor. This is also a mixed method study. Okay, now to save our time, so we go directly for the presentation delivered by Professor Tiffany Wang. Professor, the floor is yours now.
Okay, thank you for the introductions. Okay, I will show my PPT. Okay.
Of course, Professor.
And show. Oh, sorry. Let's see how. 新的分享，分享，进行分享。OK，OK， I don't know how to show. Okay. Can you see my PPT now?
Yes, Professor.
Okay. Yeah. Okay, that's fine. I want to only show this portion. It's okay. Good day, everyone. I'm very happy to be here. And today's section, I will briefly introduce about the assessment and management of COVID-19 in Taiwan. And Salamat Pagi. Assalamualaikum. Thank you.
Selamat pagi, Professor.
Thank you. And globally, there has been 179 million cases of COVID cases, and including 3.9 million deaths reported to the WHO. Most cases were reported from America, Europe, South Asia. And the COVID-19 illness is caused by the infection of SARS-CoV-2 and is associated inflammation and deregulate the immune system. And in addition to the virus can cause mostly lung symptoms. In addition to cause the lung disease, the virus also cause lots of extrapulmonary manifestations, including damage in the neural system, renal system, hepatic system, GI system, cardiac, and endocrine and skin. So a patient may have in addition to cough, shortness, and fatigue, abdominal pain, and may also have other discomforts because of the infection caused by the virus. And the COVID-19 can have, when people get infected, they may have different severity, level of severity, including asymptomatic, mild illness, moderate illness, severe illness, or critical illness. And and severe illness. And for those has mild symptoms, only lung and pulmonary symptoms like cough and shortness of breath, that's patient has mild symptom. And for patient has moderate illness, they may have abnormal chest X-rays And for those has severe illness, their pulse oxygenation will less than 94% and may have PF ratio less than 300 and respiratory rate greater than 30s. And for those has critical illness, they may show respiratory failure, septic shock, and multiple organ dysfunctions. And not all the patient will show severe illness. Some patient has even do not have any symptom. We call asymptomatic or pre-symptomatic. But some may develop very severe conditions. So from the data from China show that about 80% patients has only mild to moderate symptoms, and about 14% of patients may show severe illness, and only 5% symptomatic patients show critical illness. And globally, the overall case mortality rate is about 2.1%. So not all patients show up severe symptoms. Most patients infected by the virus only minor symptoms, and that's the dangers of the disease, because that some patients or some people they were infected but without symptoms, and so they don't know they were infected. So, but they can still transmit the illness or the disease to other persons. So that is why that's caused so many people infected around the world. So because that. Not like SARS, that when you have fever, you can transmit the disease. But for COVID, even you don't have any symptom, you can still transmit the disease. So it's very easy to spread out. So, and this is the process or the timeline for the COVID infection. So it's about intubation day is about 5 days. And so after a patient catch the virus, after 5 days, they may start to meet the median intubation day is about 5 days. And then patient may start to show fever, cough, fatigue, and then about at the 7 days, some patient may have shortness of breath. About 50% of the patient that become more symptomatic or moderate to severe illness, so they will maybe decrease their pulse oxygenations, and around 10 days. Now those severe cases, they will develop a severe illness. So, and their SpO2 may be less than 94%, and only 5% of those symptomatic cases will become critical ill, and they may need to be admitted to intensive care unit and use maybe even be intubated, use ventilations, use ventilators. And so, and this is the phase of COVID-19 illness. And so for the beginning, you can see early infection. So the virus replicate, and we call this viral response phase. So at this period, there some people, their immune system can fight with this virus, and so they may not develop severe conditions. So they may just mild symptom or no symptom at all. But some cases or some patients, they were not able to fight the virus. So the virus replicate and then cause the infiltration in the lung. We call the pulmonary phase. And then also this infection will trigger host the patient's inflammation response and even deregulate their immune response. and then will cause the hyperinflammation phases and become more severe cases, and patient may develop ARDS, SIRS, shock, or even cardiac failures. So, and in the early stage, maybe we just symptom management. In the pulmonary stage, that patient may need oxygenation support and start to use antiviral agent or anti-inflammatory agents. And then in the stage 3 or later or severe stage, that maybe we will, a patient will show elevate the CRP and also elevated the interleukin-2 and even has coagulation problems, so D-dimer will increase. And at this stage that we will continue to use the anti-inflammation agents or interleukin-6 antagonist to help the patients. And this PPT show why different patient has a different level of severity. It's because different people has different immune response. So if patient can, that is specifically for the interferon. So if a patient can have earlier or no interferon response, then they will have minor clinical disease. But for those patients that have delayed interferon response, that will trigger their immune system, so full-blown immune response or inflammation response, later they will develop a more severe disease. So mostly based on the patient's condition, their immune systems and their immune response, and then they may have different severity after they catch the virus. They get infected by the SARS-CoV-2 virus. So all these are these immune cell. So different level of immune cell like CD4, CD8, and the inflammation factor in different tummies. So you can see around day 9 or 10, those will become more severe because their inflammation or immune response become more increased or higher level of response. So during the treatment strategy, just like I said earlier, we use antiviral and then anti-inflammations. And later, because of the coagulation response, because of inflammation, and then we may use anticoagulation for this patient too. So, and for who will develop more severe illness? For those who are older and also those with underlying medical condition are high risk of group for severe illness. Those underlying medical condition including COPD, obesity, or CKD, or other immune compromised condition, or type 2 diabetes. Some other medical condition may potentially increase the risk of severity. Those are not many evidence support, but we're thinking that may be also related to a patient has severe condition like asthma, liver disease, or type 1 diabetes. So this is a potential increased risk. And these viruses, they are dangerous because they can survive in different surface and for a very longer time. Even in the body, they can, our skin can survive about 9 hours. So that make the disease more easily to transmit. So because they, that is why we need to decontaminations, so use decontaminating agents, centralized the surface of many places, so that to decrease the transmission of the virus, or also practice our hand hygiene and after, and also avoiding to touch the face, because otherwise we will transmit the virus to our mucus or our eyes and then catch the infections. And also ensure, especially healthcare workers, so we need to ensuring wear proper PPEs. So maybe the PPE that we can use that for healthcare provider, including most important N95, respiratory and facial shield, goggles, and gloves, and also isolation gown. All these can protect us from the virus infections. And most important is the vaccinations. So, and because more people vaccinated, it's difficult for the virus transmit people to people. So, because those immune the people can become act as an isolation, so that isolate these virus transmitted to those not immune to the people, because people, these infected contagious people surrounded by those immune to the people, so we can prevent the disease transmissions. However, because there is so many variants, so the SARS, the COVID-2 virus is an RNA virus, so very easy to mutate. And because this mutation will increase the risk of reinfection, so that is why there is a news that people that in the United States been infected for more than 40 times because of the virus keep mutation. And even those with vaccination, they can still get infected because of the virus mutation. So will decrease the efficacy of our vaccines. And there is many variants of the virus, including usually we say that UK variants, South Africa variants, but now WHO used the Greek later for the name of the variant. So now we call the Alpha variants, Beta variant, Gamma variant, and Delta. And now it's very dangerous of the Delta variants, because very easily to transmit it. And some of our current vaccines is because it's new variants, so some of our vaccine is not immune, not work very well to prevent the Delta variants infection. So that is why the news say that maybe in the future we need to get vaccinated, maybe for older adult every years, and for younger adult maybe a couple years need to be re-vaccinated. So future is the vaccine will be a big market. Yeah, because everyone needs the vaccine, because the virus keep mutate. So, and this is this PPT show those common signs and symptoms that people infected by the SARS-CoV-2. So, including fever, cough, shortness, breath, running nose, all these upper respiratory symptoms that non-specific symptoms, so also including some abdominal symptoms, abdominal pain, diarrhea. So it's not so easy to differentiate the disease or according to the symptoms. So that for patients that you suspect to have COVID, 19 that we will use the testing, including viral testing, nasal swab, or NAT, the RT-PCR. So it's more definitely diagnosis. So can help us to diagnose that a patient has COVID-19 or not. And also some patient that we may use the laboratory data to help us to assess the severity of their disease, and that's including the lab workup including CBC, ABG, coagulation screening, and inflammatory markers, and CRP. So that are common laboratory workout that may be used for diagnose COVID patients. And so lab finding will including increased neutrophilias, AST, ALT, CRP, and ferritins, and interleukin. All these pro-inflammatory cytokines will increase, and D-dimer increase is and also lymphopenias are associated with mortality. If we show increase the D-dimer, that's better because it will cause coagulation problems so for patients, and so increase their mortality rate. And maybe we also can assess patient using chest X-ray and chest CT, but these are not recommended for diagnosis purpose, but maybe to assess the severity of patient's condition. And in the X-ray may show up also chest CT that maybe we can see bilateral infiltrations in the lung or consolidation in the lungs. And some may also show pleural effusions, but that's rare. So these chest X-ray and CT that you can see the ground glass opacity, so that indicating bilateral infiltration can show here the white, like ground glass, like glasses here. So this is the very typical COVID-19 severe cases patients lung image. And this is just a pathway that when we evaluate a patient and stratify their risk of disease, that we can stratify them, the patient for 3 labels. First one is lower risk, and moderate risk, and higher risk for the patient. For lower risk patient is low SpO2, so their pulse oximeter is greater than 94% at room air, and their respiratory rate is less than 22. So that's patient, they may be discharged with monitor, discharged home with oxygen monitor. So, and may remind them when they need to call. And for those patients, they have SpO2 less than 94 at room air, or respiratory rate greater than 22, or have other comorbidity, that we will stratify them as the moderate risk. And those patients may need a chest X-ray and that work out. So, and then if they the condition improved after treatment, maybe antivirus treatment or oxygenation treatment, and they are after treatment their SpO2 greater than 90, they may also be discharged to home with pulse oximeter monitor. And for those with high risk is those need to be admitted maybe to hospital or to ICU and use more intensive treatment and oxygenation and ventilation. It's those that they show lung infiltrations on the X-ray and the data, the lab data work out maybe more information factors in those cases. And this for patient, mostly for COVID cases, we only monitor with their oxygen and ventilation, and the other treatment is pharmacological treatment. So the major two type of treatment for these patients. So first is oxygenation and ventilation. So, and for the mild cases, we may only need to use conventional oxygen therapy like nasal cannula or simple mask. And for those more moderate to severe cases that we need to use maybe high flow nasal cannula or non-invasive positive pressure ventilation. And for more severe cases, critical cases, they may need to be intubated and use also try the awake prone position to improve their oxygenation. So, and these are those conventional oxygenation that we may use for the mild cases, mild to moderate COVID cases. We can use low flow oxygen supply, including nasal cannula and simple mask for those patients with SpO2 greater than 94%. And for those the more severe cases, the patient with SpO2 less than 94% at room air, we may use non-rebreathing mask, or better if we have the high-frequency nasal cannula, because the high-frequency nasal cannula that as patient is more comfortable and also that can provide the humidify and also the warm air to the patients, because for COVID cases, usually they have congestion in the lung and many sputants, so that will help their secretion managing their secretion and their oxygenation and ventilation. So the high frequency nasal cannula is better than the non-rebreathing mask because of the heating and humidifying that the high frequency nasal cannula can provide. You can see these pictures. So, and when a patient use the high flow nasal cannula, that in addition to the high flow nasal cannula, you may also that patient use the surgical mask. The purpose is to decrease the droplet dispersion, so that because to prevent the virus infect our healthcare provider or other family members. So, and this patient, in addition to nasal cannula, is better to let them also wear the mask too. And this is the figure that we can see. The different treatment has different aerosol dispersion. So, like for high flow nasal cannula that has less aerosol dispersion, so that is why it's better use the high flow nasal cannula than use the NIPPB. You can see the NIPPB has more aerosol dispersion, so that will cause infection or the virus surrounding the room, and they cause infection to other people. So unless you have isolation room, so negative pressure, otherwise that in the room, otherwise we don't use NIPPB in the patient without isolation room or without the negative pressure room, because of the aerosol dispersion. And the nebulizer can cause lots of aerosol dispersion too. So that for patients, if they need a treatment, then maybe we can use the MDI instead of the nebulizers. So. And this is the oxygenation and ventilation intervention for more severe cases. So for patient that critical years patient, they already developed the ARDS. For mild ARDS, maybe you just use, usually those patients already been intubated, so that you can use the ventilator and use the low tidal volume for this patient. For all the ARDS patients, we use the low tidal volume, high frequency modality, because their lung has very high pressure. So usually we use the low tidal volume for these cases. And we also will use the PEEP, lower to moderate PEEP, to help their oxygenation. But for more severe cases, like moderate to severe ARDS, the moderate to severe ARDS usually is the patient, their PF ratio less than 200 or even less than 100. So less than 200 is moderate and less than 100 is severe ARDS. Then you may need to use the high PEEP and also may use the neuromuscular blockage. So to sedate the patient, so to let them to be more calm and their respiratory rate not fight to the ventilator, so they can get better ventilation. And for the moderate to severe ARDS, the prone position, the awake prone position will help patients for their oxygenation too, because their lung can have better oxygenation, ventilation, and perfusion. So all the lung can have the air, so they can improve their oxygenation. And for more severe cases, that maybe ECMO is needed, maybe they have a cardiac failure too. So these are oxygenation and ventilation may be used for critical year the patient. And these are awake prone position. So you ask patient to lie on their side and lie on their tummy and both sides, and also sit up. So, and because of change this position, the different area of lung can have the air and the perfusion, so that can improve the oxygenation of the patient. And usually we will do 3 times a day, and each time 3 hours. So in these 5 or 4 positions, so each one maybe at least half hour, maybe up to 2 hours. So, and so like 3 times a day, each time is 3 hours. So together is more than 9 hours a day in a different position to improve patients' oxygenation. So, and this is just real patients' pictures. So, and they and high frequency nasal cannula is good for COVID patients too, because it's easier to wear, even though patients. So this picture is not so good, because usually patients will also wear the high frequency nasal cannula for their oxygenation. So this just shows the position, so that patient needs oxygen too for this prone position. And now this picture, this PPT is shown in addition to the oxygenation and ventilation. Another important part of management is the pharmacological management. And because of the COVID-19 disease process is too main pathological process. First one is I already mentioned is in the early stage is the replication of the virus, and in the later stage is the deregulation of our inflammation or immune response to the SARS-CoV-2 to the virus. So because of different phases, 2 phases, so our treatment is focus on these 2 phases. So in the early phases, I already mentioned that we use the antiviral treatment. And in the later phases, we use the immunosuppressive or anti-inflammatory therapies. So this is main concept for COVID, 2 main concept or 2 main category of treatment for COVID patients. So this is pharmacological intervention. So actually for COVID treatment, there is not many medication we can use. So can categorize as these 4 medication groups. First one is the neutralizing antibody. So this is to give the patient the antibody against the virus, so treating the virus infection. And the second one is antiviral agent. So Randaviral. So this medication can has the antiviral effect. So these 2 categories is antiviral effects, and the 3 and 4 is anti-inflammation and anti-regulator immunity. The third one is the corticosteroid. Most medication we use is dexamethasone. So many studies show that dexamethasone only 6 milligrams per day for 10 days can decrease the mortality of the COVID. So this is the only medication that can decrease the mortality of the COVID cases. So, in addition, another anti-inflammation agent is interleukin-6 antagonist. The medication name is tocilizumab. So this medication may help for anti-inflammatory, but most important is the dexamethasone. So, and if patient CRP greater than 7.5, we may add the interleukin-6 antagonist to the dexamethasone. So, but we don't use the interleukin-6 antagonist solely use this one. We need to use it combined with the steroid. So, and the 4th category medication is the anticoagulation medication, so heparin. So 4,000 units per day. For more severe cases, maybe twice per day. So for prevention is 40 units for 4,000 units per day. This is for prevention, and twice a day maybe for treatment. So anticoagulation. So this figure just show why all those medications work. So first we treat with the neutralizing antibody, and the antiviral region is to prevent the replication of the virus. So the early stage, and the later stage, because of our body, all these cause the immune response or inflammation response, cause this cytokine storm, and these are most related to interleukin-6. That is why interleukin-6 antagonist may help. And also dexamethasone steroid, corticosteroids can related to all these cytokine storm and all other inflammation response. So that is why dexamethasone can help can improve the mortality rate of the COVID cases. And then later, because the neutrophilia infiltration will become severe ARDS, if we cannot stop the condition here, then patient may develop to severe condition and become ARDS. So then we will according to the ARDS treatment. The same as other shock cause the ARDS, similar treatment like ARDS. So this is the summary for how can we management the COVID-19. The only two parts. First one is oxygenation and ventilation, and the second part is the medication treatment. So for oxygenation, therefore, those not severe cases, so and the SpO2 greater than 94 or between 92 to 94, we can use the at room air. We can use nasal cannula, high frequency and high flow nasal cannula, and non-rebreathe mask. And for more severe cases, that we will use intubation and ventilator and manage the ARDS conditions. And so for medication, the early stage, we use antiviral treatment. And later stage, we use immune-based treatment and also anti-coagulation treatment or coagulation prevention, so anti-thrombolytic treatment. So only three categories of this treatment type. And this is the summary of how can we assess and the management COVID-19 disease based on the illness severity. So for those asymptomatic patients, they may have positive test results, and maybe just in the incubation period, they stay home, nothing needed. So, but when patient develop COVID symptoms and X-ray is negative, so no lung condition yet, but just upper respiratory symptoms. So, and that usually in illness, the first 4 to 5 days, and then maybe a patient for prevention admit to the hospital at the ward. So, and during the pathological stage, this stage is replication of virus, no other treatment, and no oxygen needed, and no ventilator needed. At this stage, maybe we can start to use antibody or use the antibody to neutralize the virus. And moderate state illness is patient with SpO2 greater than 94, but they have sign and symptom of lower respiratory infections. So this is about day 6 to day 7. So, and at this time, patient may need oxygen supply and also can use antibody treatment. And when patient has SpO2 less than 94 or PF ratio less than 300 or respiratory rate greater than 30, that patient has severe condition. That's only about 40% symptomatic patient has this condition. And this about in the disease stage about a second week, day 8 to 9, and patient may be admitted to the hospital and even to the ICU. So this stage, the pathologic process is deregulate immune and inflammatory response to the virus, and patient needs high flow nasal cannula or even mechanical ventilations, and we can use the medication that dexamethasone 6 ml per day, IV is better, or PO also can use, and for 10 days. And for some patient with CRP greater than 75, maybe we can also combine use antiviral medication. Also, for critical year, that patient has ARDS that only counts about 5% of those patients and start about more than day 10, so day 11. And patient may need mechanical ventilations, and we can use steroid and also interleukin-6 antagonist or anticoagulation medications. So this is the summary that for how we can assess and also manage the COVID-19 cases and for different stage of the cases and different illness of the cases. So in conclusion, that the knowledge I show you, how can we manage the COVID-19 come from the misfortune of many patients around the world, and many healthcare providers, they die from the disease also, and their efforts, and also many medical scientists efforts, so we can know so many about this disease. And the care of COVID-19 is a team battle. In the face of COVID-19, that we must take care of ourselves and our teammates as well. So that's all I want to share with you today, and thank you for your listening. And welcome for your questions.
Okay. So one more time, give a virtual applause to Professor Tiffany Wang for a wonderful presentation. Okay. And right, for the next, I believe that some of you have so many questions to Professor Tiffany for the wonderful presentation. Now I would like you to invite for the discussion or question and answer session. So please, the webinar participant, if you have any questions, so you may raise your hand virtually, or you can write in our chat room. Is there any participant who would like to join a question and answer? Okay, first question from chat room questions, Professor. So we have first questions from Mr. Sukarman. Mrs. Wang, in Indonesia, there are many comorbidities that cause the severity of COVID-19, namely diabetes mellitus. If the slide mentioned the most comorbid cardiovascular disorder, so what is the explanation? Is the vaccine effective for all variants of COVID? So that's the question from Mr. Sukarman, Professor. Would you like please give the explanations about that question?
Okay, thank you for the questions, and that's a good questions. I think type 2, the diabetes also very, it also the common condition for higher risk when patient has type 2 diabetes. So I think that's the same as in other country, and also cardiovascular conditions, but also because the severe cases is related to our immune response, so that could be genetic difference area from area too. So different country may have different ethnic group. They may have response differently to the virus. So I think that's not a big pathological differences. I think it's same as my PPT that show DM also a severe important comorbidity for patient have severe illness. And is the vaccine effective for all variants of COVID? I think some vaccines work better with more variants of the COVID, like the Moderna and also the Pfizer's, but some work less effective for other variant, especially for Delta variant like AZ. We know that AZ vaccine, I think it's because this vaccine use different technology to develop, like so for AZ and for Johnson & Johnson seems less effective because those technology used to develop those vaccines. And for Moderna, for BNT or Pfizer's, they use different technology, and those may work better for entire COVID condition, also work for more different variants. So.
Right. Okay, thank you, Professor, for the wonderful explanation. So hopefully to Mr. Scorman, this is really answering your questions. And we have another question. Okay, so we have a live question, Professor. So to those who... Okay. Right, go ahead, sir.
Okay. Hello, Prof. Tiffany.
Hi.
Good morning. I address you from Indonesia. Okay. Prof. Tiffany, this is a great explanation for me. Because I have two questions for you. If I remember that respiratory disease, I remember that COVID-19 that stuck is a lot in the world, especially for Indonesia. You know, COVID-19 stuck in Indonesia recently is for the rate of die is so high. So this is my questions. Why do people who got COVID-19 die? Must be dying? This is for the first questions. For the second questions, does COVID-19 have different types, Prof. Tiffany? This is my questions. Thank you.
Okay, Professor. So you may have the explanations about the question.
Can you repeat the question? So is the COVID-19, some patient die earlier, you mean?
Yeah. COVID-19 recently is stuck a lot, especially for Indonesia. You know, for the rest of die, Indonesia is so high of dying. This is my questions. Why do people who got COVID-19 disease, especially in Indonesia, must be dying and die like that? And for the second questions, does COVID-19 have different types? This is my question for. Thank you.
So you mean the higher mortality rate of COVID-19 in Indonesia, right? Or the patient died very fast in Indonesia?
The people, I describe the COVID-19 in Indonesia because COVID-19 is starts a lot, especially for Indonesia and in the world. This is my questions. Why do people who got COVID-19 die? They are dying. So that the rates of die, especially in Indonesia, recently is so high. COVID-19 stuck and die like that. For the second, does COVID-19 have different types, Prof?
Okay, Professor, if I can repeat the question is, in our country, Indonesia, people with COVID-19, so mostly they are dying. So why people with COVID-19 in Indonesia, mostly of them are dying? For first questions. And then the second question, if I'm not mistaken, is there any type? So is there any type of COVID-19?
COVID-19.
Right. So the question is like that, Professor.
Okay. My answer is I'm not sure about the screening of COVID-19, do you have screening, like larger population screening for COVID-19? If not, it's only those show up symptoms, you know they have COVID-19. So those they don't have symptoms, you don't know they have COVID, they get infected. That is why in my country too, our mortality rate is higher than the global. It's because we don't screening our population. So we don't know how many people were infected without symptoms. So that is why all we know is they have severe symptoms, because when they have severe condition, they come to the hospital and then we test them. Then we know they are COVID cases. If they don't have symptoms, they don't come to the hospital. We don't know they are cases. Actually, they are. They were infected and they continue to transmit the disease to other people without knowing. So that is why, and you see the COVID cases die early. Actually, because those cases you see are those severe cases. I think in my country it's the same. And there is very different variants, so different type of virus that can cause because the SARS-CoV-2 virus can mutate. So there is alpha, beta, and gamma, different type of the virus. So that is why patients, even they recovered from their COVID-19, from their disease, they can still get infected because they were infected by other type of the virus or other variant of the virus. So yes, but the symptom is similar. So, but for some variants, they may have more change their smell and change their taste. But some variant they have sneezing. So different variant they may have different symptoms. But if they become severe cases, in the late response, all similar, because the severe cases, they have ARDS. That is because our immune system cause our immune response and also those inflammation response. So cause our lung infiltration and those disease, they are similar. In the end, they are similar. But at the beginning, they may have different symptoms. Yeah, because of different variants. So different type of the virus. Yeah. It's the same virus, but different mutation, so it's different subtype of the virus. Thank you for the questions.
Okay, thank you very much for the wonderful explanations for the questions. And to Mr. Anwari, does it answer the question? Yes, okay. So we move to another question, Professor. So the same questions from Mr. Sukarmin. He would like to ask one more time. Ask again, Professor Tivani, which variation of COVID therapy are effective in Taiwan using any drug derivative? So that's the question, Professor.
Which variation of COVID therapy are effective in Taiwan use any drug directives? I think most effective pharmacological therapy is the dexamethasone. So all the patient with, and also oxygenation, and maybe because the antibody and antivirus medication is more expensive. So in our country that we need to apply for that because we have health universal coverage for our health care. So those costly medication that we need to apply for it. But all the patient that we can use the steroid, the dexamethasone, and those effective, and also combine using the oxygenation that can help patients.
Okay,
Does
thank
this
you.
answer your question?
All right, then we still have any questions? email? Okay. So so everyone, I still open one question if you have any. One more questions? One last questions? No? Okay, seems like there is no more question, Professor Tiffany. And I really thank you for the wonderful presentation in the second session. And before we close this session, so would you like to please give your closing statement, Professor? So would you please give your closing statement, Professor?
Oh, closing statement.
Okay.
Okay. Okay. Thank you for listening to this section's lectures, and I'm very happy that be able to participate in this international conference. And may you have a great day and all learn a lot about whatever you help you for your future professional careers. And thank you for your participations.
Okay, you're most welcome, Professor Tiffany. And one more time, I would like to say thank you very much for Professor Tiffany Wang for the wonderful presentation in this session. And Professor, we see you in the next presentation. Thank you very much. Have a nice day, Professor.
You too. Bye-bye.
Goodbye. Well, ladies and gentlemen, while preparing for the third session, so yeah, I'd like to say one more time thank you for the Taiwan International Healthcare Training Center and also Central Escobar University for supporting this conference. And so now we come to the third session. So the presentation from Professor Bisma Murthy. So let me keep in touch with the professor first. Hello, Professor.
Hello.
Have you been joining us? Okay, Professor Bisma Murthy had connected with us. Now we can go directly for the third presentation. So Professor Bisma Murthy today will talk about stunting. And before he delivered the wonderful presentation, do you have any photo session with Professor Bisma Murthy? Yes? Okay, hold on a second, Professor. So Professor Bisma Murthy is very familiar for us. So he is our supervisor. How are you today, sir?
Good, thank you.
Professor? Okay. Now we have Mr. Rusnata joined for this webinar.
Oke, foto dulu ya, Prof.
Ya, silakan.
So I also invite for the webinar participant to join a photo session together with Professor Bisma Murthy. Please now stay on your camera. Okay, 1, 2, 3. Again, 1, 2, 3. Okay, 1, 2, 3. Okay, now freestyle, Professor. 1, 2, 3. 1, 2, 3. Okay. Okay, so now last time photo session with no must. 1, 2, 3. 1, 2, 3. Okay. Freestyle now. Okay, thank you very much. Okay, well, ladies and gentlemen, now we come to the third session of the presentation. And now we have Professor Bisma Murthy. And today he will talk about stunting in our country, Indonesia. But before he delivered the wonderful presentation, so let me read a brief about his curriculum vitae. So his full name is Bisma Murthy. The institutions of him is Master Program of Public Health Graduate School, Universitas 11 Maret. His office address is on Jalan Insinyur Sutami 36A, Surakarta 56126, Indonesia. Okay, and about the education, so he completed the Doctor of Philosophy or PhD in Health Economic at Center for Clinical Epidemiology and Biostatistics, University of Newcastle, Australia. And also he completed the Master of Science in Health Economic, University of York, UK, and Master of Public Health, MPH in Epidemiology and Biostatistics in Tulane School of Public Health and Tropical Medicine, New Orleans, LA, USA, and also Medical Doctor, Faculty of Medicine, Erlangga University, Surabaya, Indonesia. About his current position, he is now a Professor of Public Health, Department of Public Health, Faculty of Medicine, Universitas 11 Maret, and also had a Master Program of Public Health, Graduate School, Universitas 11 Maret, and also chair the International Conference on Public Health, or we call ECPH. About the international consultancy, so he is also a visiting professor at University College London, University of Bergen, Norway, 2009, and for the World Health Organization, short-term consultant posted in Myanmar. And about the award that he had along his career, so first is Erasmus Mundus Scholar, European Union in 2009, University of Newcastle Research Scholarship and Overseas Postgraduate Research Scholarship, and Stint Visiting Fellow at Epidemiology, Department of Public Health and Clinical Medicine, and also Utawa Fellow. And then British Chevening Award, British Council, British Government, 1996 to 1997, and etc. I think there are many awards that he gave. Okay, to save our time, so and now we will go directly for the presentation delivered by Professor Bisma Murthy. Professor, the floor is yours, sir.
Yeah, excuse me. I must wait for the azan to complete about 3 minutes.
Yes, sir.
I have to wait for the azan for 3 minutes.
Yes, of course, sir.
Okay, thank you. Thank you for the moderator who has introduced myself. Mentioning my CV, short CV. Good afternoon, everybody.
Good afternoon, Professor.
First of all, I would like to thank everyone for coming in this international webinar today. Secondly, I'm grateful to Mr. Rusnoto, Rector of Universitas Muhammadiyah Kudus, who has invited me to be one of the resource persons. I also would like to appreciate Ms. Ani Rosiana, the Vice Rector for Students and Collaboration Affairs, who has made good communication in preparation for this talk. This afternoon, this session, I will discuss the topic titled Stunting and Community Nursing. For this purpose, let me share the slides for you to see. Yeah, as you can see on the screen, my topic is stunting and community nursing. This is in part of the international webinar conducted by Universitas Muhammadiyah Kudus. In these slides, I will discuss a topic in stunting and community nursing, and I will present in 4 parts. Part 1, I will talk about the scope of community nursing and the roles of community nurses. Secondly, I will talk about the essential skills of community nurses. And thirdly, I will discuss about multi-factors associated with stunting. And the fourth, I will describe about the recommended strategies to combat childhood stunting. What is the definition of nursing? According to the International Council of Nurses, nursing encompasses autonomous and collaborative care of individuals of all ages, families, groups, and communities, sick or well, and in all settings. Nursing includes the promotion of health, prevention of illness, and the care of ill, disabled, and dying people.
Professor Bisma, may I have an interruption, please? The slide could not be displayed in a screen, sir.
Let me try again.
Okay, the Mitra agent, please now share the screen from Professor Bisma. Okay, sir, we are now preparing for the slide. Okay, Professor, the slide is ready. Professor Wismamurthy, the floor is yours now, sir.
Oh, so you will help me operating this slides?
Yes, sir.
Okay, no problem. So this is operated by you, the stunting and community nursing. Okay.
Yep.
Yeah, as you can see in the slides, my topic is stunting and community nursing. This is the objective, or in the slides, I will discuss a topic in stunting and community nursing, and I will present in 4 parts. The first part is the scope and community nursing and the roles of community nurses. Secondly, I will talk about the essential skills of community nurses. And thirdly, I will discuss about multi-factors associated with stunting. And fourth, I will discuss about the recommended strategies to combat childhood stunting. Next, please. What is the definition of nursing? According to the International Council of Nurses, nursing is defined as an autonomous and collaborative care of individuals of all ages, families, groups, and communities, either sex or well, in all settings. Nursing includes promotion of health, prevention of illness, and the care of ill, disabled, and dying people. Advocacy, promotion of safe environment, research, participation in shaping health policy, in patient and health system management, and also education are another key role of nurses. Next, please. So now, what is community nursing? Community nursing combines primary health care and nursing practice in community setting. It's also called public health nursing or community health nursing. Yeah, next. The definition of public health nursing is the practice of promoting and protecting the health of population using knowledge from nursing, social, and public health sciences. This is according to the American Public Health Association. Next. What are the roles of community nurses? Unlike a nurse who works one-on-one with patients, the community nurses focus on communities. The various roles of a nurse in a community setting may include: first, health education; second, community advocacy; third, ensuring a safe and healthy environment; fourth, policy reform; fifth, community development. The specific roles depend, of course, on the community need. Next. What is community advocacy? Advocacy means public support for or recommendation of a particular cause or policy. Community advocacy is community support to equip them, by them we mean community, with the knowledge and skills to be able for them to deal with health and social care services with confidence. Community advocacy helps the community to be involved in decision-making about their lives, access of information, and understanding of their human rights. What are the essential skills of community nurses? The essential skills include analysis and assessment, policy development and program planning, communication, cultural competency, community dimension of practice, public health sciences, financial planning and management, and also leadership and systems thinking. An example of essential skills is nurses' cultural competency. Community nurses should be aware and adapt with the local culture. For example, they must recognize customs and respect mores in order to communicate effectively with the communities. Nurses need to build relationships and gain trust in these communities in order to allow effective cooperation with the communities. The layers where the community nurses works is multiple. This includes micro level, such as individual care. This is at the level of micro, and then meso level, such as community development, exo level, including healthcare provision, and macro level, including policy development. So now we go on to the topic of stunting. What is stunting? Stunting is the impaired, by impaired we mean disorder or abnormality in growth and development that children experience from poor nutrition, repeated infection, and inadequate psychosocial stimulation. What is the definition of stunting? Children with stunting is defined as stunted if their height for age is more than 2 standard deviations below the WHO child growth standards median. Yes. Next. So why are we here discussing about stunting? Why is stunting an important public health problem? First, childhood stunting has been associated with increased risk of morbidity and mortality, as well as increased risk of obesity and other metabolic complications in later life. Stunting impacts negatively both physical growth and cognitive development, which impede stunted children to achieve their full height and cognitive potentials as adults, and subsequently will lead to lower economic productivity and constrained social function. Globally, stunting affects approximately 162 million children under the age of 5 years. And the prevalence of child stunting in Indonesia also had remained high at approximately 37% by 2017. Stunting is one of the endorsed target by the World Health Assembly in 2012. Besides anemia, low birth weight, childhood overweight, exclusive breastfeeding, and wasting. As you can see, the target is reduction in the prevalence of stunting down to 40%. Next. What causes stunting? Stunting has multiple causes. Factors that contribute to stunted growth and development include poor maternal health and nutrition, inadequate or non-responsive infant and young child feeding practice, infection, both clinically and subclinically, and then inadequate child stimulation, food insecurity, and household poverty. All these factors can interact to impede growth and development. Next. And determinants of childhood stunting in Indonesia, firstly is male sex, meaning that male children have higher risk of experiencing stunting than the female counterparts. Secondly, premature birth. Third, short birth length. Fourth, non-exclusive breastfeeding for the first 6 months. Fifth, short maternal height, low maternal education, low household socioeconomic status, living in a household with unimproved latrine and untreated drinking water, poor access to healthcare, and finally, living in rural areas. This is a framework of factors associated with stunting among children under 5 years of age. As you can see, there are 3 layers or 3 levels of factors, including immediate factors like underlying factors and basic factors. So this framework is based on the UNICEF conceptual framework. As you can see, we can start reading or looking at the top. Child undernutrition, including stunting, is affected by 2 categories of cause. One is dietary intake and problem in dietary intake and requirement, and the other side is disease occurrence. And these 2 parts is called immediate factors. These immediate factors are affected by the underlying factors. For example, dietary intake and requirements are affected by household food security, environment, and services, including healthcare services. On the other part, disease occurrence is also affected by environment and services, including healthcare services, and also socioeconomic statuses. And these underlying factors are affected by, on the bottom line, the basic factors, including sociopolitical, or we can say the macro context. Next. This slide tells about the Brazilian experience, about the key factors contributing to success in stunting reduction. In Brazil, stunting among children aged under 5 years dropped from 37, so similar to Indonesia now, in 1974 to only 7% in 2007. The 5 key factors which have contributed to the success of combating malnutrition in Brazil is improvement in the purchasing power of families through increases of minimum wage and expansion of cash transfer programs. Secondly, a rise in the rates of female education. Third, improvement and expansion of maternal and child health services. Fourth, expansion of water and sanitation system. Fifth, improvement in the quality and quantity of food produced by small family farms. Yeah. This is another article. This is based on a systematic review reporting about the evidence-based approach to childhood stunting in low and middle income countries. This article, in essence, reported that for all low and middle income countries setting, a combination of interventions was associated with success when they include health and nutrition outcomes, as well as social safety nets. Next. Yeah. This article taken from Lancet in 2013, it states that the protection of nutrition, let alone acceleration of progress, will entail more than bringing nutrition-specific intervention to scale. Now, what's a nutrition-specific program? Nutrition-specific program address the immediate determinants of fetal and child nutrition and development, such as adequate food and nutrition intake, feeding, caregiving and parenting practice, and low burden of infectious disease. This is different from nutrition-sensitive program. Next, please. This is a list of nutrition-specific intervention and programs. This including health and nutrition during adolescence, preconception, pregnancy, and lactation, and then maternal dietary and micronutrient supplementation, promotion of optimum breastfeeding, complementary feeding and responsive feeding practice, and feeding stimulation, dietary supplementation, food diversification, micronutrient supplementation or fortification for children, treatment of severe acute malnutrition, disease prevention and management, and nutrition in emergency. These are called nutrition-specific interventions. Next. And what is nutrition-sensitive? Previously, it was nutrition-specific program, and this one is nutrition-sensitive program. This refers to the underlying determinants of fetal and child nutrition and development, such as food security, adequate caregiving resources at the maternal, household, and community levels, and access to healthcare services, a safe and hygienic environment, incorporating specific nutrition goals and action. And nutrition sensitive programs can serve as the delivery platform for nutrition-specific intervention, potentially increasing their scale, coverage, and effectiveness. So it's better to combine them. And this is a list of nutrition-sensitive intervention and programs, including agriculture and food security, social safety net, early child development, maternal mental health, women's empowerment, child protection, schooling, water, sanitation and hygiene, health and family planning services. And then it was mentioned about social safety net. Social safety net provide cash or food transfers to poor people and victims of shocks, for example, natural disasters. Social safety nets are a powerful poverty reduction instrument as long as their potential to benefit maternal and child nutrition and development is to be unleashed or to be released by strengthening the nutrition programs and interventions, as well as the quality of services. And I think this is the final slides. This is a framework for action to achieve optimum fetal and child nutrition. As you can see on the top is the benefit during the life course. So if you want to intervene, if you want to reduce stunting, you should use life course approach. Life course approach from the gestational period to the adulthood. Benefit during the life course, you can see on the left-hand side, reduction in the morbidity and mortality in childhood, increase in cognitive, motor, social, emotional development, increase in school performance and learning capacity, increase in adult stature, decrease in obesity and non-communicable diseases, and increase in work capacity and productivity. And this can be achieved if we have optimum fetal and child nutrition and development. As you can see on the left-hand side, it's a list of the nutrition-specific intervention and programs. On the right-hand side, nutrition-sensitive programs and approaches. This can be used to program to achieve optimum fetal and child nutrition development. I think next. I think this is the last slide. Concluding remarks. Yeah. Community nurses can make a great impact on stunting reduction and improving public health as a whole by working together interprofessionally and in partnership with the communities, providing quality maternal and child health care related to stunting, as well as supporting policy, advocacy, and education at the highest levels. Programs combining nutrition-specific and nutrition-sensitive intervention with context considerations are recommended to optimize reduction in stunting. Thank you. Yeah.
Thank you very much, Professor Bismamurti. Now, please give applause virtually once again to Professor Bismamurti for the wonderful presentation. Right, I think we have many questions for the presentation delivered by Professor Bismamurti. Then I will go directly for the discussion session or question and answer session. So please everyone, the webinar participant, if you have any questions now, you can raise your hand virtually or you can writing your question in our chat room, please. Is there any live question? Once again, I remind for the webinar participant, if you have still a question to Professor Bismamurti, you may raise your hand. And you may chat also in our chat room. One question?
Halo, Assalamualaikum Prof. Bisma.
Okay, seems we have one question. Okay, go ahead, sir.
Okay. Halo, Prof.
Yeah, hello. Yeah.
Okay, Assalamualaikum Prof. Bisma. Good afternoon.
Is this from Anwari?
Yeah.
Yeah, thank you.
Okay, thank you very much for your explanation. This is a great explanation for me. And I'm so glad because I found you today, even though I got you in front of this camera. Your terms relate to stunting, and this is part of disease for the people. And this my questions. Okay, this is if we are talking about stunting, this is related to weight and height of the body. This is small, under bracket small. And my questions in how to distinguish based on stunting and genetic of trait mother and father. Thank you. So.
Okay, so if I can repeat the question, Professor. So, is that possible? The stunting can be derived from father and mother. That was the question,
Yeah.
Mr. Anwari.
How to distinguish this is stunting or not, or this is genetic from mother or father?
Yeah.
Yes.
Yes, Professor Risma.
Yeah. Let me show my slide. Have you seen my slides? moderator. Have you
Yes,
seen
sir.
my slide?
Yes, sir. We are preparing that.
No, from myself, not from you. I'm sharing my slides to the screen. Have you seen it?
Not yet, Professor. Yes?
Wait a second. Have you seen the slides?
Yes, Professor.
My slides, not from your side, but from yeah.
Yeah, I got it.
To answer your question, Mr. Anwari, thank you for the question. By definition, stunting, a child with stunting condition, this is, as you can see on the slides, definition by WHO, children is defined as stunted or as categorized as stunted if he or she has height or age is more than 2 standard deviations below the WHO child growth standards median. For example, -3 below standard below median. This is the children and this child is classified as stunted based on height or age scores. This to be distinguished, for example, with wasting. Wasting is another undernutrition condition, which is defined as weight for height, not height for age, but weight for height, more than 2 standard deviations below the median. And then your question is possible, as you can see, one of the causal factor is the short maternal height. Jadi ibu yang pendek, short maternal height, especially the maternal, especially ibu, not the father, especially the mother. So it can be inherited by the mothers. One of the factors affecting the occurrence of stunting is short maternal height. Is that what you are questioning?
Okay, so to Mr. Anwari, does it answer the question?
Yes, I got it. Thank you, Prof.
Okay, so thank you for Professor Bismarck for the wonderful explanation. Now we come to the next question, please. Is there any chat room questions? Okay. Okay, so let me read the question from our chat room, please. Okay, so the next question, sir. Question from Miss Armel. bagaimana tata laksana stunting komunitas, sir? So the question is in bahasa Indonesia.
Yeah, I will show you again the slides. Do you still see the slides, Mr. Moderator?
Yes, sir.
Yeah. The interventions between community to community would be different, yeah? But basically it's a combination of nutrition specific programs like this, nutrition specific program on the left hand side, and nutrition sensitive programs. It's better than you emphasize only on the nutrition specific intervention programs. Why? Because the causal factors of stunting rest on many levels and several levels. As I mentioned before, it can be at the micro level or individual level, household level, or at the meso level, such as community development, but also at the exo level regarding the provision of healthcare, and also macro level, the political context. So we have to address also this one on the right hand side, nutrition sensitive program and approaches. So once again, you have to couple, you have to combine both nutrition specific intervention program and then inside the program there is a set of intervention or activities. These activities will vary from community to community. So you don't have to deliver all this intervention to a specific community. So you have to firstly to assess the community needs. You have to analyze what the community need in order to reduce the stunting problem. And this will determine the kinds of intervention to be provided for that community. Also, this also apply for the nutrition sensitive programs. Once again, you don't have to deliver all of these interventions, but you have to select according to the community need. This is my answer to the last question.
Okay, thank you, sir, for the wonderful explanation, and hopefully for Ms. Amalia, this is really answer the question. And we will move another question, please. Okay, so right, we have one more question, sir. The question from Ibu Sari. Ketika anak usia lebih dari 2 tahun, tetapi mengalami stunting, apa yang harus dilakukan? So the question is in bahasa Indonesia. That's the question, sir.
Yeah. There is a good question here. So the earlier identified, the better. So for stunting is a chronic condition. It's different from undernutrition. In Indonesian, we call gizi kurang atau gizi buruk. It's different from that. Even it's different from wasting. stunting is a reflection or representation of chronic lack of resources experienced by the child. So we have to, or the community nurse should emphasize on the prevention and also the promotion as early as possible. So your question, if that happens after the child has reached 6 years old, for example, then I think, although you cannot reverse the height of this child to be normal, but you can still make improvement in height with the better nutrition for that child. Although to reverse, to achieve the normal height is not possible. And then don't forget to support this child in attending schooling, in attending education, basic education. They have to be supported. They have to be advocated in order for them. For example, they have to be selected to the right method of educating, because they have slower cognitive competency than the normal children. So we still have opportunity to improve the physical and cognitive development, although the gain and the gain or the achievement of this effort is very minimal. That's my answer to the last question.
Okay, that's the wonderful explanation from Professor Bismamurthy. And then we move to another question. Maybe one last question. No more questions? Okay, so one more time I invite for the last question, if any. If not, I will close this session, of course. No? Okay, one more time, Professor Bismamurthy, thank you for the wonderful presentation. Before I close this session, please, Professor, give the closing statement.
I just want to repeat these concluding remarks.
Yeah.
So those who has nurses qualifications, you can make a great impact on stunting reduction and improving public health as a whole by working together interprofessionally and in partnership with the community themselves to provide quality maternal and nutritional health care for the mothers and children related to stunting, as well as supporting policy, advocacy, education at the highest level. You have to remember that stunting only can be we can only deal with the problem of stunting if we combine both nutrition specific and nutrition sensitive interventions in one package. That's all for the concluding remarks.
One more time, thank you very much, Professor. Before I end this session, so I'd like to say thank you one more time, and Sir, you have a say greeting from our rector, Mr. Rusnata. He is here.
Oke. Terima kasih Pak Rusnoto. Thank you very
Terima
much.
kasih Prof. Bisma bisa memberikan materi di kesempatan kali ini di webinar internasional. Kami dari Universitas Tuberculosis terima kasih sekali. Selamat siang, Prof.
Ya, selamat siang. UNS dan lockdown sampai 2 Juli.
Nggih, Prof.
Ya, kalau ke Solo setelah 2 Juli.
Nggih, Prof. So thank you for the wonderful presentation one more time, and give applause virtually to our professor, Professor Bisma Murti PhD. And we see you in the next presentation, sir. Thank you very much and have a nice day.
Moderator, thank you very much.
Yes, sir. Well, ladies and gentlemen, we still have last presentation. Of course, this is also a very, very wonderful presentation. The presentation from Mrs. Indana. So before she deliver the presentation, so today she will talk about also stunting, and we will have a kind of a photo session together with Bu Indana.
No.
Virtually. No. Okay. Let's go to. Okay. Let's go directly for the presentation. Bu Indana, so have you been connected with us? Bu
Yes.
Indana, how are you today? Okay,
Yes, I'm fine today.
Alhamdulillah. Okay, so before she deliver the wonderful presentation, let me read her curriculum vitae first. Her full name is Indana. So now she is a lecturer and dean of the faculty. Her home address is in Jalan Ledjen R. Suprapto, number 86, RT1 and RW4, Kuaron, Gubuk, Grobogan, 58164. And about the education, so she finished for the bachelor degree at PSIK Faculty of Medicine, Divanagari University in 2001, and also nurse in PSIK, also from the Divanagari University, and Magister of Nursing at Universitas Indonesia, and also specialist for child nursing in Universitas Indonesia at 2011. And about the educational background, she begins her career as a lecturer at Akper Yakpernas Banyumas, and also now she is a dean of the health faculty of Universitas Muhammadiyah Kudus. The association that she had been has been joined. So first is PPNI, second is Ikatan Perawat Anak Nasional Indonesia or IPANI, and the third is ADI. About her publication, there are so many publications that I can mention one by one. So at least she get a HKI for nutrisi anak and dengan gangguan hepatobiliar, and also she is famous with the article entitled Perilaku Antisosial pada Remaja, and etc. Okay, so to save our time, let's go directly for the last presentation delivered by Mrs. Indana. Now the floor is yours, Mom.
Yeah, thank you. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thanks for moderator to have given me time. Thanks Mr. Rector. Today I will present my PowerPoint about stunting. Before I'm talking about stunting, a lot of discussion about stunting. First, I would like to introduce myself. My name is Indana. I'm Dean of Health Science Faculty Universitas of Muhammadiyah Kudus. I'm so glad today I'm able to attend in the forum because I have no more health master and specialists from various countries, especially Manila, Taiwan, Malaysia, and Indonesia itself. Okay, on this occasion I will discuss about stunting. Why stunting? Because stunting rate in Indonesia is still high. It is caused by a lack nutrition intake for a long time, resulting in growth disorder in children, namely the height is shorter than the standard age. How to recognize stunting and how about prevent it? This is important to learn and understand because as parents, especially for service, nursing, and we must know for the maximum development to children growth. Okay, please help me to share my screen. Thank you. Yes. My PowerPoint, the importance of preventing stunting. Next, how about stunting? Stunting, children are defined as stunting as their height for egg less than 2 standard deviation based on World Health Organization Child Growth Standard Median. Body length less than -2 standard deviation. Next, look at the picture. Next. Next, Miss. Yeah. After this, okay. After before this, bukan? Yes. Okay. Yes. We can see this picture. This is stunting being done from one age. The picture above you can see children of the same age, but they have different height, shorter than his age. That's calling a stunting. Next. How about stunting in Indonesia? World Health Organization said that Indonesia is including into third country with the highest prevalence in the Southeast Asia region. The average prevalence of stunting under 5 in Indonesia in 2005 to 2012 was 36.4%. Next. Stunting, if we talk about stunting, stunting is a major nutrition problem facing Indonesia. Based on nutrition status monitoring data for the last 3 years, short men have the highest prevalence compared to other nutritional problems such as undernutrition, underwork, and obesity. The prevalence of stunting toddler has increased from 27.5% in 2016 and 27.6% in 2017. Next. This is a nutritional problem. We can see for the chart. Every country in the world got a nutritional problem. Indonesia is one of countries that has triple burden of nutritional problem. Based on data from 2013 to 2018, it can be seen that stunting is still a major nutritional problem compared to other nutritional problem, obesity, malnutrition, but stunting was number one problem in nutritional problem. Next. Nutritional problem in Indonesia from 2015 and 2017 we can see in the table. From the table we can see that from year to year the problem of stunting is still the highest nutritional problem compared to other nutritional problem. Next. How about stunting? Causes of stunting have a 4.2 causes of stunting. 1. Food security. 2. Social environment. 3. Health environment. And 4. Residential neighborhood. The direct cause of nutritional problem in children include stunting is low nutritional intake and health status. The nutritional stunting focus on addressing the cause of nutritional problem, namely factor related to food security, especially access to nutritional food. Social environment related to infant and child feeding practice by caregiver, access to health service for prevention and treatment health, environment health, which includes the available to clean water and sanitation facilities. Therefore, factors affect the nutritional intake and health status of mother and children. Intervention against these four factors are expected to prevent nutritional problems, both undernutrition and excess nutrition. The growth and development in children influenced by environmental factor and hereditary factor. Research by Du Bois show that heredity only for 7% in women affect 2% of height of birth. In contrast, the influence and environment factor at birth was very large. This proves that supportive environment conditions can help children growth and development. Based on case of stunting children the future will have difficulty in achieving optimally physical and cognitive development. Before the impact of stunting. What the impact of stunting? The impact of stunting is the problem of stunting at an early age, especially in the first 1,000 days of life. It will have an impact on quality of human resource. Stunting causes the organ of the body to not grow and develop optimally. Stunting toddler contribute 15% death on children under 5 in the world, causing 55 million disability adjusted life year. The loss of healthy lifespan each year. So we talked about the impact of stunting. Have to short term and long term. How the impact of stunting in short term? Fail to thrive, bear to cognitive and motor developmental, not optimal physical size and body of the body and metabolic disorder. This is short term the impact of stunting. So for long term, the impact of stunting expressed by decreased intellectual capability, disorder of the structure and function of nerves and brain cells that the permanent, and cause of the decrease in the ability to absorb listen to school. It will affect the productivity as adult. Malnutrition also cause growth disorder, increase the risk of non-communicable disease such as diabetes mellitus, hypertension, coronary heart disease, and stroke. Next, how the impact of stunting on the quality of human resource. We can see for the graphic picture. This stunting in the brain development, and after this healthy child brain development. We can in the picture 1 it can see that the first picture show the condition of brain cell is stunting children. Picture 2 show the condition of healthy children brain cell. It can be seen that healthy children have more and more complex brain cell network. How is impact to stunting to the quality of human resource? 1. Fail to grow. Low birth weight, small, short, and thin. And number 2, impact number 2, barrier to cognitive and motor development, influence on brain development, educational success. And number 3, metabolic disorder in adulthood, increased risk non-communicable disease, diabetes mellitus, obesity, stroke, and heart disease. Next, we can see the cycle of stunting. We have 5 period to cycle of the stunting. 1. The cycle of stunting. A mother who has malnutrition during pregnancy is at risk to giving birth to a baby with low birth weight. Baby with low birth weight will affect their growth and development and at risk of experience stunting. Stunting children currently have a risk of becoming malnutrition in teenager. This is sustainable to that the handler must start from the gestation period until the optimizing of the growth and development. Prevent of stunting. Basically stunting. Next. Preventing of stunting. Stunting can be prevented the first 1,000 days of life, 9-month pregnant period, 6-month breastfeeding period, and 18-month breastfeeding and complementary feeding. So that's the first 1,000 days of life. Why is the 2-year-old as the priority? We can see the picture. Nah, why priority until 2-year-old? Because brain development is the fastest since in the womb until 2-year-old. This is the first 1,000 days. Next. So we can talk about main component of stunting preventing. Have three point to main component of stunting preventing: parenting, diet habit, clean water, and sanitation. Now, what about the parenting? We can talk about parenting. Main component of stunting preventing component parenting: health and nutrition education before and during pregnancy, early initiation of breastfeeding immediately after birth. So exclusive breastfeeding for 6 months, continuing breastfeeding up to 2-year-old, and complementary feeding. Good health service like immunization. Next. Main component of stunting preventing dietary habit: provision of food according to nutritional need based on egg, food, side dishes, vegetable, and fruit. So next, main component of stunting preventing: clean water and sanitation. Clean water, family toileting, washing hands. This is a component of stunting to preventing. Next, specific of nutritional intervention. Number 1 is pregnant mother, breastfeeding mother, and children aged 6 months, breastfeeding mother, and children aged 23 months. Specific of nutrition intervention, we can supplementary feeding pregnant woman, complete iron and folic acid deficiency, overcoming iodine deficiency, overcoming intestinal worm in pregnant woman, and protect pregnant woman from malaria atau or infectious disease. Next, specific of nutrition intervention: breastfeeding mother and children 0 and 6 months. Improve the implementation of early initiation of breastfeeding and administration of colostrum. That's exclusive breastfeeding. Specific of nutritional intervention: breastfeeding mother and child 7 and 23 months, breastfeeding, providing zinc supplement, prefer warm medicine, fortification of iron in food, complement immunization, and diarrhea prevention. Yes, this is the role of nutrition and stimulation to prevent stunting. Integrated early childhood development for the first 1,000 days. 5 major of nutritional risk factor for poor early childhood development, integrated developmental stimulation, and nutritional intervention. So we can see the role of nutrition and stimulation to prevent stunting, poor mother nutrition status, severe malnutrition, iodine deficiency during pregnancy, poor linear growth, Fa deficiency. This is 5 major of nutrition risk factor for poor early childhood development for the first 1,000 days. How about child growth monitoring? What is about monitoring? One, growth deviation, development deviation, and mental and emotional deviation of children's speech. Growth deviation, malnutrition, affect children's growth or stunting. Development deviation, talking loud, speech delay. So, mental of emotional deviation of children impair concentration and hyperactivity. Improve the children quality as an effort to prevent stunting. One, we use early detection, monitoring regularly and periodically from an early age. Two, early stimulation, optimizing early stimulation according to the child developmental state. Three, early intervention. Take early intervention if there are deviation. So, early deviation growth, one way to early deviation by screening method. We in Indonesia have a Depkes RI and Ikatan Dokter Anak Indonesia have a good guidebook of stimulasi and implementation, early detection and intervention of child development in Indonesia SDID3 IDTK, early detection for growth irregularity, early detection of developmental deviation, and early detection of emotional deviations. Child developmental describe the increase in the maturity of individual function, must be monitored regularly. Infants or children with high risk need to get priority. Include premature baby, low birth weight, history of asphyxia, hyperbilirubinemia, intrapartum infection, mother with diabetes mellitus. So, this early detection instrument. When should detect early? When should detect early? According to the Indonesia Ministry of Health, the right time to early detection is for children 1 to 24 months. Detecting can be done every 3 months. In children 0 to 6 years, detection is done every 6 months. Next. Early detection of children development. We can see for the chart. This early detection for children development. Next, early detection of development deviation as to child development with the KPSP pre-screening development questionnaire starting at the 3 months, at least every 3 months until 2 years old, at least every 6 months after 6 and 6 years old. Hearing question for children with TDD, hearing power test starting at the age of 3 months, at least every 3 months until 1 year old, at least every 6 months until the age of 6 years old. Vision test of children with TDL, vision test 3 years old every 6 months. So, early detection of emotional mental deviation, mental of emotional problem questionnaire for children 36, 72 months, preschool autist checklist for autists in toddler, chart for children at 18 after 36 months, early detection for attention deficit and hyperactive disorder, GPPH or ADHD, for children aged 36 months and more. So, early detection for growth regularity, measurement for of weight and head circumference. We can see how to early detection of growth irregularity. This is instrument for early detecting of growth deviation. We have a growth curve, length for egg for boys, length for egg for girl. This is for stunting. This category of children nutrition status dari Kementerian Kesehatan. This This is this category of children nutritional status. Child development describe the increase. Next, Miss. Child development describe the increase in the maturity of individual function. We use Denver. Denver 2 is a developmental screening tool to find out as early as possible developmental deviation that occur in children from birth to 6 years of age. Early detection of growth and development by Minister of Health Development pre-screening questionnaire. Next, early detection of development pre-screening questionnaire, an instrument to track progress, fill out of the form 9 to 10 question developmental ability that has been achieved. Schedule 3 and 24 month, 3 month for 3 month every 3 months. Schedule for 24 month every 6 months. Examiner, hot worker, kindergarten teacher training teacher. Denver progress screening, the function of Denver 2, assess developmental level according to age, assessing developmental from birth 1 and 6 years old, catching children without symptoms for potential developmental abnormalities, confirming the suspicion of child development disorder, monitoring the development of children at risk. This conclusion, I think, is last presentation. Stunting monitoring is required regularly according to schedule. Appropriate instrument we use World Health Organization growth chart. Stunting if blank for egg under mean to standard deviation. Schedule 3 months every 3 months before 24 months. Every 6 months before 60 months. I think it's my presentation, Mr. Safik. This reference we used to make a presentation. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you one more time to Mrs. Indana for the wonderful presentation in session 4. And of course, we will have a discussion session or question and answer session after the presentation. So now I would like to invite all webinar participants once again to involve in a discussion session. Please, if you have any question, you may raise your hand and also writing question in the chat room. Is there any? Okay, so I think this is a very wonderful presentation from Mrs. Indana talking about stunting today, and we are glad if you all have participate for this session, this question and answer session. We have any? Okay, we have one question. All right then, so let me read the question. The question from Ibu Sari to Mrs. Indana. Based on the explanation, 2 years is very important for the nutritional status, but many children is now difficult to eat. So would you please explain about this, Ibu?
Yes, thank you, Mr. Safik. Please, I will to answer in Indonesian. Please,
Okay.
translating.
Yes, sir.
Ya.
Yes, mom.
Untuk anak yang usia 2 tahun dan kebetulan tidak bisa makan, ya pastinya kita harus melihat dari banyak aspek. Yang pertama dari aspek anak, dan yang kedua adalah dari aspek orang tua. Kalau dari aspek anak, adakah permasalahan kesehatan yang membuat anak itu tidak nafsu makan? Terus kemudian yang kedua, kalau dari aspek orang tua, apakah orang tua sudah menyiapkan secara bervariatif makanan yang harus disiapkan sesuai dengan usia anak? Nah, sehingga kalau mau memberikan makanan kepada anak supaya dia lebih sering makan atau lebih tertarik untuk makan, berarti harus lebih variatif, variatif dalam penyajian makan. Terima kasih Pak Sofik. Thank you Miss Sari.
Yeah, okay, so the answer is quite clear in Bahasa Indonesia, but let me give a little bit explanation in English. So, Mrs. Indana tried to explain that there are two aspects, yeah, both parents and children. So why the children could not eat after 2 years? So if it is coming from the children, so we should determine what is the problem, why the children could not eat or could not have any having good meal. And meanwhile, if it is coming from parents, so parents should know what is the best meal for the children itself, and parent of course need to prepare what is the best meal for their children, if I'm not mistaken, like that explanation, Indana. So thank you, and we move to the next question, please. One more questions, if any. Okay, so please show the questions. Yeah, we still have time to have the discussion. If you have any question, please all the webinar participants to join the question and answer session. Okay, second question is, no? Okay. Yeah, okay. So the next question coming from Ryan Aryan. So the question is, talking about stunting, the children have enough nutrition, but the height is still not best on the table. It means the height is not standard. So what is the explanation, Mrs. Indana, please?
Yes. In bahasa Inggris Indonesia ya, Pak?
Okay.
Yes. Ada 4 tahap atau 4 siklus stunting. Yang pertama dari ibu, terus kemudian dari bayi yang dilahirkan, dari anak itu sendiri, dan dari calon ibu. Sehingga kalau anak sudah dapat makan dengan baik, ternyata tumbuh kembangnya atau tingginya tidak sesuai dengan yang sebenarnya or stunting. Nah, review kembali apakah ibu dulu juga mengalami malnutrisi atau mungkin masalah kesehatan selama masa kehamilan. Itu yang pertama. Yang kedua, pastinya ketika ibu mengalami masalah kesehatan selama kehamilan, yang terjadi kemungkinan anak lahir dengan berat badan rendah. Cek kembali apakah anak lahir dengan berat badan rendah. Ya, apalagi atau anak lahir dengan usia gestasi muda. Nah, faktor itulah yang lebih beresiko mengalami stunting. Kalau sudah stunting, tata laksananya berarti support stimulasi, support gizi, ya kan? Dan optimalisasi tumbuh kembang sampai batas usia, sehingga tidak akan menjadi calon ibu, calon ayah yang nanti berisiko menjadi melahirkan anak stunting juga. It's sampun Pak.
Okay, so the answer is very clear in Bahasa Indonesia, but I just repeat one more time into English to those who would like to hear the answer in the English versions. So based on Ibu Indan explanations, there are 4 steps of a cyclist in having stunting. Yeah. So first coming from mother, and then second baby, and then third is the child, and the 4th is the mother's candidate. So we would like to review one more time. So please review if there is a malnutrition among mothers who give birth for the children itself. So if yes, now try to give a better nutrition, so to avoid the stunting itself. And the second is about the problem in pregnancy. So during the pregnancy, you may check one more time. Yeah, if you got any problems, so now please try to balance. And if it is can lead to the stunting another time. So this is the explanation from Mrs. Indana about this question. So hopefully to those who ask the questions, can we understand? Yes? Is there any? Finish? Okay, seems there are no more questions for this session, and before I'm closing this presentation, so I will turn in to Ibu or Ms. Indana to please give a closing statement, Mom.
Yes. We have 4 cycle of stunting. Stunting child, malnutrition young child, malnutrition mother, and underweight baby. The intervention of stunting mass intervention for 4 aspects of cycle of stunting. I think it's that.
Thank you one more time. So now let's give applause virtually to Mrs. Indana for the wonderful presentation in the last presentation. And seems like the time is up. I would like to say thank you for all webinar participants, about 400 and maybe 1,500 in the morning, joining this webinar series holding by Universitas Muhammadiyah Kudus in collaboration with Taiwan International Healthcare Training Center and also Central Scholar University. And thank you one more time before I close. So I'd like to say Alhamdulillah first in running well for this webinar. Alhamdulillahi Rabbil Alamin. So for me, if I have any mistake, let me say sorry to be a moderator for this webinar. Thank you very much. Billahi sabil haq fastabil khairat. Assalamualaikum warahmatullahi wabarakatuh. We see you in the second webinar series. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.